Start, sir. We are live.
Good evening and namaskar everyone. I welcome you all for live webinar on the second day of management of early lung and breast cancer. And with immense pleasure, I would like to invite Dr. Nitish Garg, who is Assistant Professor Medical Oncology at American Oncology Institute, Dayanand Medical College and Hospital, Ludhiana, for the welcome and introductory note and to set the ball rolling. The stage is all yours. Over to you.
Thank you, Ms. Ekta. As yesterday we have discussed about management of early breast cancer. So today, keeping the ball rolling, we'll talk about management of not so early, but a resectable lung cancer, rather, I should say. So we know it is a very uncommon disease to get a resectable lung cancer in India, but sometimes and few patients will come in that situation. So we need to understand the exact management, that how we have to go for this, go ahead with the staging of these patients and to evaluate them correctly so that we can provide them with the best possible treatment. So, with that context, I would like to call upon my dear friend and a surgical oncologist, Dr. Abhitesh Singh, for the first talk. So, Dr. Abhitesh is a surgical oncologist consultant at Specialty Hospital, Ambala. So, he will give his talk on management, on evaluation of mediastinal staging and role of EBUS in lung cancer management. Over to you, Abhitesh, and welcome.
Thank you, Dr. Nitish, for giving me the opportunity to discuss this rather controversial topic, how to stage the mediastinum in lung cancer. And as you already told, there are very few instances where we get to, stage the mediastinum. The patient really rarely comes to us in such a resectable state that we can plan such a mediastinal staging. So I'll be starting with my slides. Are you able to see the screen?
Yes, we are able to see, and definitely, as you told, it is one of the difficult management and difficult to manage and stage the disease. So definitely, I would be very keen to listen to you. What are your thoughts, and how do you, as a surgical oncologist, you manage these cases? Over to you, Abhitesh.
Thank you. Mediastinal staging, whenever we diagnose any malignancy for that matter, we have to stage it. We have to have a clinical examination, staging, imaging, and a tissue diagnosis. So these all are the requirements, as all of us know, to start the treatment. So today I'll be concentrating on the staging part, and today I'll be concentrating mainly on the staging part as well as the tissue diagnosis. So required before we begin the treatment. So what is the importance of the end stage? So mediastinal staging is basically the nodal staging. So if we have any N0 or N1 disease, we are probably looking at doing an upfront surgery. If we have any N2 disease, then in case of an N2 disease, then we have to probably go for NA's neoadjuvant CT based on other patient factors or a definitive CTRT. And in an N3 disease, we definitely have to go for a CTRT itself. So which are the operable patients? So these are all the N1 disease, N0, N1 disease, and N1 N0 and N1 disease are the operable patients. So N1 are mainly the hilar nodes, and N2 are the ipsilateral, paratracheal, and the paraesophageal nodes. N3, any nodes beyond that, upper cervical are always N3, and any contralateral mediastinal nodes. So those are the contralateral hilar nodes or the contralateral paratracheal nodes. So those are the N3 nodes. So why do we need a thorough mediastinal staging? Because usually most of the places, even we experience that based on the PET CT finding, most of the times we start the treatment. But PET CT is definitely going to understage or overstage the patient based on the current stage of the patient. If in case the patient is understaged, then we are omitting some local therapy. If the patient is under stage, then we are giving the patient unnecessary local therapy, whereas systemic therapy is omitted. So it may result in a lower survival. And if we are overstaging the patient via PET scan, which is quite common, considering the prevalence of tuberculosis and other granulomatous diseases in our population. So in those cases, then we are giving unnecessary chemotherapy, again omitting the required local therapy, which may result in a lower survival. So what are the guidelines for mediastinal staging? So first line investigation is invariably EBUS or a combination of EBUS and EUS, endoscopic ultrasound. And if we have a non-diagnostic or a negative EBUS, so then we have to go ahead with a mediastinoscope, invasive mediastinal staging, which is usually a mediastinoscopy. So for invasive mediastinal staging, gold standard is still the mediastinoscopy only. The various approaches available for this staging are either surgical, endoscopic, or image guided. So surgical staging is the standard cervical mediastinoscopy, VATS, anterior mediastinoscopy, and nowadays we have video-assisted mediastinal lymphadenectomy and extended cervical mediastinoscopy also. So the endoscopic staging consists of EBUS, EUS, or a simple blind transbronchial needle aspiration, which is usually done for if we don't have a facility for EBUS and there are suspicious subcarinal nodes, then we can go ahead with a transbronchial needle aspiration too. And image guided staging can be done via CT guided transthoracic needle aspiration, but it is rarely done by any intervention radiologist owing to the proximity of major blood vessels to the mediastinal nodes. So this is, I'll just briefly describe what mediastinoscopy is. We just give a small incision above the suprasternal notch, and then with blunt dissection, we make a space just anterior to the trachea and posterior to the great vessels. So here we can visualize the paratracheal nodes and the subcarinal nodes. So these are the stations which are accessible. The stations which are not accessible are mainly the AP window, station 5 and station 6. So another modality which is now likely replace the mediastinoscopy is the VAMLA. So this is the mediastinoscope, video-assisted mediastinoscopic lymph node dissection. So with the help of this scope, we introduce our conventional laparoscopy instruments. So we can introduce those instruments also and do a paratracheal lymph node dissection. So the benefit, so this is a VAMLA. We connect the scope here, and using this suction and other instruments like cautery and a grasper, so we can do the N2 node dissection even prior to taking up the patient for definitive surgery. So, but the drawback of this procedure is that there are higher chances of any major vessel injury, which may lead to unintended sternotomy, or we can there are chances that we may damage the recurrent laryngeal nerve also. So although we get a very good staging, but the complication rate is a little bit higher. So when do we do an EBUS? So we can diagnose any intrapulmonary tumors. We can have a lymph node staging. There is any unknown mediastinal lymphadenopathy, which we don't know the cause of, and any mediastinal tumors. So again, in lung cancer, EBUS can help us in diagnosis, staging, in case of a recurrent setting, and we can even have, if we have a facility of cell block, then we can have molecular studies also done with this. So this was a randomized controlled trial published in 2013, I believe. So 2015, published in Lancet. So in this, they randomized the two arms based on the CT staging into either a conventional diagnosis and staging or EBUS TBNA. So the interesting findings were that firstly, the delay in treatment was shorter in EBUS TBNA compared to conventional diagnostic staging, and the number of procedures which were required were significantly lower. 2.3 procedures in the conventional staging, and endobronchial staging required on an average 1.7 procedures to accurately stage the mediastinum, and which according to this article was the basis of improved survival because of start in early therapy which was attributed to start in early therapy in the EBUS arm. So another meta-analysis for the sensitivity and specificity of EBUS. So again, it showed that we have close to 90 to 99% sensitivity and specificity for mediastinal staging. So this sensitivity, when combined, when seen in the recurrent setting or post-systemic therapy setting, we have similar sensitivity and specificity for EBUS and EUS. So this was mainly for when we have an N0 or N1 disease, but we have a centrally located tumor, the chances that we encounter we have an upstaging due to pathological N2 nodes is quite high. So close to 35%. So based on the findings, if we have a centrally located tumor or a peripherally located large tumor, so in those cases also, in N0 disease 2, we can go ahead with the EBUS for accurate staging so that we don't upstage the patient at the time of surgery. So this was another meta-analysis which showed that around only 5% of the patient, 4.89% of patients, the disease was upstaged. So whether these 5% of patients warrant EBUS in N0, N1 lung cancer patients is still controversial. So combined EBUS EUS, as I have previously told, it is better than EBUS alone because we are able to sample the lower mediastinal station 7 and station 8 nodes in addition to the paratracheal and parabronchial nodes. So again, when in previously treated lung cancer patients also, when we have to see whether there is a recurrence or how the disease response. Again, EBUS has a higher accuracy compared to FDG PET and CT alone. So then comes the question of, because nowadays mostly we have to do molecular analysis. If we have an adenocarcinoma, then we have a larger panel to run the test, EGFR, ALK, ROS. So this meta-analysis has shown that most of the times we are able to get sufficient tissue for molecular analysis, even with a EBUS TBNA approach. So again, mostly for squamous cell carcinomas, we prefer doing a PDL1. So in those cases also, this meta-analysis showed we can have adequate sampling. So to conclude, mediastinal evaluation is of prime importance in treatment planning, and sequence of investigation must be well thought out. CT scan and a PET scan still form the basis of planning for staging, and mediastinoscopy still is the historical gold standard. But sequencing of mediastinal staging after endoscopic procedures, it reduces the number of invasive procedures and may contribute to decrease in morbidity. And it can be another benefit of EBUS is that without having any tissue diagnosis from the primary, if we find that there is a patient is having a lung mass and along with that patient has an N2 or N3 node. So with a single investigation, we can prove that the node is positive, as well as we can have. So that is the diagnosis, and it will also give us the stage also. So, and the benefit of combining EUS is that we can even cover the lower mediastinum when we combine EUS and EBUS both. And provided we have a good pathology backup, we can have sufficient tissue for molecular studies in EBUS FNA patients. Thank you.
All right. So thank you, Avitesh, for this wonderful talk on mediastinoscopy and EBUS role in resectable lung. So I actually have a doubt. I had a patient who was 63-year-old with the T4 disease. The T size was 7 centimeter involving the visceral pleura, but as per the PET, there was no nodes. He did on examination. There were no supraclavicular lymph nodes also. So I went ahead for a conventional CT-RT regimen, omitted the mediastinoscopy as per the surgical oncologist. He was deemed inoperable in case we are planning for a surgical procedure. Should I have done a mediastinoscopy in that case? Would it have changed my approach?
Again, we should have a media. First thing we should, which we should definitely go for, is a mediastinal staging. Simply based on PET scan, we should not start the treatment. So the first first investigation, because it is, we have less morbidity related to it, so we should go for a EBUS FNA if we have resources available. If we have backup for, we have a pulmonary medicine department who have a good experience in EBUS, then we can definitely go for EBUS staging with the EBUS. So then, based on the findings, whether we have any highly suspicious necrotic nodes in the mediastinum or we don't have, so based on that, we have to then further decide whether to go for a mediastinoscopy or not. But at least a EBUS should have been done.
So if I would have done a EBUS, so should I take the FNA from multiple nodes which I encounter in the area surrounding the mediastinum, or a single node is beneficial? So that is always my doubt, that in case I'm going ahead with the EBUS, so what next to be done? Single node, multiple nodes, in case they are negative.
So it basically depends on what the protocol is of the pulmonary medicine department at your place. But as per the guidelines, we should sample all the N3 to N2 to N1. All nodes should be sampled, and starting with this sequence itself, N3 first, followed by N2, followed by N1, so that any even our syringe can sometimes, if we take a positive N1 node first, even our syringe can contaminate our N3 or N2 node sample. So ideally, we should take N3 node followed by N2 followed by N1. But if we have sometimes such a convincing node on the PET scan, so like there is a big subcarinal 3 centimeter node, necrosis is there. So to prove that, we can definitely shorten the procedure. We can take a single sample from that node, but not the ideal case.
So in case it is node negative on PET, there are no nodes, no uptake, no necrosis mentioned. Shall we still do sampling of all the nodes which we encounter? Yes.
It should be. Mediastinal staging is a must. PET cannot, basically, as we all know, PET is basically for metastatic workup. It has nothing to do with our decision whether to do a mediastinoscopy or not.
Right. So thank you, Avitesh, for this wonderful talk.
Thank you.
In case any questions, I'll still trouble you again. So moving on to our next speaker. So I'll invite Dr. Debashish Chaudhary. Sir is principal consultant surgical oncologist, oncology at Max Hospital, Saket and Gurgaon. So he is specialized in basically treating breast and thoracic cancers. So I would like Sir to take the call on role of surgery in a resectable cancer and what next after the surgery has been done. Over to you, sir.
Thank you, Nitish, for this invite, and thank you, Avitesh, for a very wonderful, enlightening talk. So I will stick to my topic. Can somebody share? I had shared my slide. Can somebody upload it, or should I do it from here? Yeah. So my topic is very crisp, I would say, as academic point of view, but it is very rare to find, as we all know. The number of operable lung cancers which we see as a thoracic surgeon is very less. It is almost only, I would say, 15 to 25% of all the lung cancer that are diagnosed. Next slide. The previous one. So this is a brief overview of the discussion that we are going to have. So what comprises the early stage lung cancer and why should we operate? What will be the surgical approaches? A minimal invasive, either a VATS robotic versus an open approach. What kind of surgery should be adequate? It should be a lobectomy, it should be a segmentectomy, or it should be a wedge resection. And the lymph node dissection, it should be a systematic lymph node dissection versus a sampling. Also we'll touch upon the post-operative outcomes and the role of adding any systemic therapy to surgery. Next slide. So whenever we talk about surgery, in most of the solid cancers, the one thing that comes to mind is the disease control. So of all the options which we have, the best disease control is achieved with surgery. And we all know the lesser the stage, the better are the chances of disease control and the long-term survival. So this is just a graph to show the excellent outcomes of surgery in early stage lung cancer. It is almost, next slide, please. It almost varies from 92 to 78%. So what comprises the early stage lung cancer? So it's a very small lesion. About T1 is less than 1 centimeter and T1B is 1 to 2 centimeters. Then we see T1C, it is more than 2 to 3 centimeters. And then we have T2, T2A, which are more than 3 centimeter and less than 4, that is between 3 to 4 centimeters. And anything that is more than 4 centimeter, usually we consider them for a neoadjuvant therapy, or if it's a node positive, then we consider them for a neoadjuvant therapy. So the scope of early stage lung cancer is only confined where we have only a single modality of treatment. So this, next slide, please. So this is the stage grouping. We see that T1 is divided into T1A, T1B, and T1C, and T2 is T2 central, which may involve the visceral pleura, or it may be a T2A lesion that is 3 to 4 centimeters. So these all types of T stage comprise the stage 1, and all should be node negative. So what are the treatment options? If we want to discuss about the variety of options which we have for lung cancer, it may be a surgery, it may be a radiation, SBRT, or it may be a RFA thermal ablation. So what guides the treatment basis is the patient and the tumor characteristics. So in the previous slide, I had already discussed. See, we can see the excellent outcomes of surgery. It's up to the tune of 92 to 74% for stage 1. And as the PT size increases, the 5-year survival comes down. So the lesser the tumor size, the better is the survival. So again, NCCN recommendation, I won't go into the details because we anyways are going to study about how we plan a surgery. The previous speaker already discussed about the mediastinal staging, so I won't be going into the details. Next slide. So coming on to the approach. So these are the conventional approach of open surgery on the left side and the minimal invasive surgery that may be either a VATS or robotic on the right side. Next slide. So again, if we talk about either a minimal invasive, that may be a VATS or it may be a robotic, there are two conventional ways. It may be a multiportal approach where we use multiple trocars, and or it may be a uniportal where we do only a single utility incision and a separate camera port, and we use that utility port for all the dissection and specimen removal. So this is one of the cases that I had recently done through a uniportal approach. Next slide. This is another form that shows the multiportal approach, that we are using multiple trocar sites, and that was the outcome. The larger incision was the utility that was used for the removal of the tumor. Next slide. So coming on to the outcome, we all know that nowadays robotic is having a little edge as compared to laparoscopy or VATS, wherever it may be. So there are various reasons to it. First is the depth perception. It's a 3D vision. It has a very steady camera. It has a very steady functional arms. So when we see about the outcomes, we see that there are reduced blood loss, there is a better pain control, and there is an improved post-operative vital capacity when we talk about robotic versus the video cystic thoracoscopic surgery, although the oncological outcomes are totally same in both the approaches. Next slide. So I had previously mentioned also the RADS versus the VADS. They are almost same compared with the oncological outcome. However, robotic may not be available everywhere. It needs a certain level of expertise, and cost is a concern. And if we talk about, if I share my experience, then I would say the cost difference between a VADS versus a robotic will be somewhere. Only the difference, if I talk about, will be somewhere around 1.5 to about 2 lakh. So that additional cost is one of the things that hinders to the optimal, to the large scale use of robotic surgery. So obviously minimal invasive has its benefit if we see the return of functionality to the patient. If we use a minimal invasive surgery, by the end of 3 to 4 months, the patient is totally back to normal. However, an open approach has a long-lasting effect. There is a lesser pain, there is a faster recovery, there is a less blood loss, and there is a lot of evidence to it that both the approaches are totally oncologically same. If we talk about the R0 resection rate, both are same. If we talk about the lymph node yield, they are totally same. And if you also talk about the clearance, that is also same in both the approaches. Next. So these are some of the evidence that shows the equivalence, oncological equivalence of both the approaches, open versus the minimal invasive. Next slide. Next slide. So the pain scores, if you see the pain scores after open versus a minimal invasive surgery on post-operative day 1, the graphs are almost matching, but the lines start to separate. That means the minimal invasive approaches will have a very less pain from post-operative day 2 onwards. So that the previous slide was just to show that data. Next slide. So what should be adequate surgery for a local tumor control? So I would say if I am given a choice, my choice will be a lobectomy first. Obviously, surgery will be first. If patient is not a suitable candidate for surgery, then we will go for non-surgical options, out of which SBRT scores better as compared to an RFA. If we talk only about surgery, then out of surgery also, lobectomy is shown to have the best local control and least local failures. Then comes segmentectomy, and then comes wedge resection. So that is the priority if we wish to choose a surgical approach out of the available options. So lobectomy is the standard of treatment as of now. There are various evidence to support that lobectomy gives a better disease control. It has a lesser chance of reoccurrence. Next slide. So obviously the patient's performance status and his pulmonary function will decide whether the patient is going to tolerate a lobectomy. If we see that the patient is not a candidate for lobectomy because of his deranged pulmonary functions, and obviously a sublobar resection, that may be either a segmentectomy or a wedge resection, should be preferred. Next slide. So this is just another study to mention the lobectomy versus the sublobar resections. In a properly selected patients, sublobar resections have been shown to be equivalent to lobectomy, but for not all cases, and these cases should be very properly selected. Next slide. So it is just to highlight the same thing which I reiterated in the previous slide, that lobectomy has a better disease control and a lesser chance of reoccurrence. Next slide. So when we talk about something that is less than a lobectomy, what are the patient subgroups? So patients who are medically inoperable, then we should think about sublobar resections, or whether tumor size is less than 2 centimeter. Even in those situations, sublobar resection can be offered. Obviously, segmentectomy is challenging. Even a wedge resection is okay, but the margins of wedge should be at least 2 centimeters. Another thing is when the pure ground glass nodules and the part of solid nodules with a consolidation to tumor size ratio is less than 0.25 centimeter. In those situations also, sublobar resections can be preferred. Another situation is adenocarcinoma in situ or a minimally invasive adenocarcinoma consisting of lipidic pattern without invasion, or only less than 0.5 centimeter invasion, that can be preferred for a sublobar resections. Next slide. So obviously a segmental approach will be a better, because the lesser part of lung will be removed. It will have a sustained, it will have a better pulmonary function test if we compare in those terms. So at the end of 1 year follow-up, the pulmonary function improvement was 3.5% statistically significant as compared to lobectomy. Obviously, the local recurrence will be more in case patients are not properly selected. So segmentectomy should be preferred only where the tumor size is less than 2 centimeters. Next slide. Again, segmentectomy versus wedge. A segmentectomy should be preferred over a wedge, because again, a wedge should have a margin of more than 2 centimeters. Segmentectomy is a challenging surgery, and post-operative it is associated with a lot of air leaks. So I won't say it is easy to go, but definitely it is challenging and should be attempted only at high volume centers. Next slide. So segmentectomy versus lobectomy in small peripheral small cell lung cancer, there was a multi-center open phase 3 trial, and it showed a non-inferiority, randomized control non-inferiority trial for stage 1A non-small cell lung cancer, tumor size less than 2 centimeter. The 5-year overall survival was 94.3% for segmentectomy and 91.1% for lobectomy. 5-year relapse-free survival 88% for segmentectomy and 88% for lobectomy. You can see the local relapse rate were little higher for segmentectomy, and it was almost double for a lobectomy versus a segmentectomy. Next slide. So segmentectomy should be preferred only when the tumor size is less than 2 centimeter. We have discussed in the previous slide. It is just another slide to consolidate that fact. Next slide. So what should be adequate lymph node sampling? So systematic lymph node sampling versus a systematic lymph node dissection, what should be preferred? So for stage 1, it doesn't matter, but wherever the lymph nodes are enlarged, so all those lymph nodes, it should be removed as a template. So in those situations, a systematic lymph node dissection is preferred. However, for stage 1 lung cancer, I would say systematic lymph node sampling, and each station should be sampled with at least 2 lymph nodes. So that kind of approach is found to be okay as compared to a lymph node dissection. But definitely the various lymph nodes should be sampled in a systematic manner. Next slide. So obviously, for any lung surgery, the lymph node sampling is must. It may be the institute's policy whether you go for a lymph node dissection versus a sampling. In our institute, we mostly do a lymph node sampling, and it will be decided what tumor location it is. The outcomes are similar for a lymph node dissection versus a sampling. Next slide. This we have previously discussed. The results of surgery are excellent, and obviously, as the tumor size increases, the outcomes start to come down. Next slide. So if we talk only about the early stage lung cancer, that is stage 1, there is no role of any adjuvant therapy. However, in a situation where there is a R1 or a R2 resection, if there is a scope of revision surgery, that should be preferred. If the revision surgery is difficult or challenging, then post-operative radiation should be added. Next slide. So this is the concluding slide. I would say lobectomy is the minimum procedure of choice. Segmentectomy can be considered in a very highly selected group where the tumor size is less than 2 cm. Systematic lymph node dissection improves staging and survival and should be done in all lung cancers. Lobe-specific lymph node dissection is another alternative method. Next slide. So minimal invasive surgery is definitely better as compared to open surgery with a comparable oncological outcome. However, the recovery and the functional outcomes are better with a minimally invasive approaches. Robotic surgery adds a little advantage over the VATS, but obviously it has its own challenging and logistic. It may not be feasible at all the places, and that is my concluding slide. I would be happy to take any questions.
Thank you, sir, for the wonderful talk on the surgical resection part of a early lung or a resectable lung. So definitely we see a very few cases. So I have a couple of questions. I would like you to know your viewpoint on this. Sometimes in a very young patient, we feel that the tumor size is about 4 centimeters. One single lymph node positive on PET, and the mediastinoscopy or EBUS shows that only single node is positive, rest of the nodes are negative. So sometimes there is an approach that we reduce the volume of the disease with a neoadjuvant chemotherapy approach. Post neoadjuvant chemo, do you feel the surgery becomes difficult? Because I have seen a patient having a normal PFT, and after chemotherapy, I'm not sure why, the PFT is worsened. So it may be the side effect of chemotherapy. The patient was not so young, but yeah, he was in 50s. So does that happen commonly? And do we use neoadjuvant approach, neoadjuvant chemotherapy followed by surgery common?
Yeah. So what we follow here is that any tumor that is more than 4 centimeter, number one, any node positive, and that has to be proven with either an invasive or a non-invasive approach, that is the EBUS. It has to be proven pathologically. We don't go by the PET findings alone. So any situation, tumor more than 4 centimeter or a node positive, we prefer a neoadjuvant chemotherapy with immunotherapy if the patient is affording, especially after the Checkmate 816, the things are changing now.
Yes.
I would say my experience is very limited to neoadjuvant chemotherapy alone, but definitely after neoadjuvant chemotherapy with immunotherapy, surgery becomes little difficult. In fact, there has been various literature that would say that you will find that the conversion rate after neoadjuvant chemotherapy with immunotherapy is more. There are anecdotal evidence to it. Some studies say that the conversion rate is not so different, but if you ask me, there is a lot of fibrosis after neoadjuvant chemotherapy with immunotherapy because of obviously the immune flare and surgery.
Yeah.
We have a couple of times we had to open the surgery because the lymph nodes where the tumor was initially present, it becomes totally fibrous, and that especially happens near the hilum area where you don't want to have any chances because there lies the major vascular structure. So surgery is definitely challenging with the chemotherapy and immunotherapy.
Yes. So, and maybe the immunotherapy increases the features of reduces the pulmonary function test in the lung because of certain amount of fibrosis, though it might not be that great for the patient to present with the symptoms, but for a surgeon to plan a surgery according to the PFT may be becoming difficult on that part. So definitely, sir, and thank you for this wonderful talk. And I would love to trouble you again, as I told Abhitesh also.
Thank you.
Wonderful. Thank you, sir. Thank you for your talk. So moving on to our next speaker. So I would like to invite Dr. Sarthak Tandon, sir. He's a senior consultant radiation oncologist from prestigious Rajiv Gandhi Cancer Institute, New Delhi. So he will be talking on role of radiotherapy in early lung cancer tumors. Over to you, sir. I invite you for your talk.
Yeah, thank you, Dr. Nitish. I hope everybody can hear me. Thank you for calling me. And I'm sorry I joined a little late because of Delhi traffic, and I got a little late. But what I've heard till now, and it's been an enlightening experience. So as you've already given me a topic regarding what is the role of radiotherapy in early lung tumors. So can you move on to the next slide, please? Yeah, thank you. So we all know that the Indian scenario is a little different from the Western scenario. Can you move on the next, please? So over the data that we've seen in a couple of years, the Globocon has suggested that even though the incidence of Western data is decreasing, the Indian data in the comparison, when we're compiling our data, the incidence of lung cancer is increasing. So we need to have an Indian answer to this global question, where what needs to be done for Indian population. We know that the IHCs and the histopaths, they are completely different in comparison to the Western populations. Next, please. So this is the ICMR 2018 data, which suggested that lung is the third most common cancer. Next. Right. So we all know, this is just reiterating the data that we all know, that what is the role of managing medically inoperable early lung cancers, and do we have level 1 evidence? The question is not what to treat or probably what modality to treat. The question is what technique in which modality. So there was a lot of question regarding whether we have level 1 evidence for SABR in comparison to a conventional radiotherapy, and we didn't have that data. Though the intuitive thought process suggested that doing SABR in early lung cancer tumors was better, but we still had only phase 1, phase 2 data before the presentation, before the outcome of this trial. Next, please. Next. So yeah, so this is the major data that I was talking about in medically inoperable. So we had 2 non-randomized retrospective series and 1 systematic review, but none of them suggested a level 1 evidence until the presentation of Chisel. Next. So this was the first phase 2 trial which came out space, which was comparing SABR versus conventional RT, and then they showed that probably SABR is better, it has better toxic effect, but none of the survival advantage that we were looking after. But this had a lot of issues, this trial, and we moved on to phase 3. Next. And this is an absolute level 1 evidence which has shown that with regards to SABR in comparison to a conventional radiotherapy, the freedom from local treatment failure and as well as overall survival was significantly higher for SABR, and that's what we're looking for in level 1 evidence. And as of now, in medically inoperable, SABR is the standard line of treatment, and that's something that needs to be put across. Next. So why Chisel was better than space is because of certain radiation specific issues. The dose was better, the technique was better, the PET, the staging workup with PET CT was better, the EBUS mediastinal staging was better. So all these factors made Chisel better. And this also made us aware of the fact that when you are using SABR and when you are using SBRT for early lung tumors, you need to have a robust staging workup, you need to have robust radiation management procedures, and as well as techniques. And that's only when you will be able to translate into an overall survival. Next, please. So this is various fractionation schedules for medically inoperable. We know this is something which is very standard. We practice it usually. I mean, we go as high as 34 grains single fraction for ideal tumors, 2 centimeters, probably 1 centimeter away from the peripheral chest wall, and probably 1 centimeter away from the central lung. Next. Now, the question which is still unanswered is what needs to be done for medically operable patients. And that's something that the great debate still flashes. And I mean, we have a lot of trials which have been stopped due to poor accrual, and they have been suboptimal data in regards with SABR. And therefore, the comparison between surgery has never given us an answer as to which modality is better. Next, please. So these are all the, single arm and phase 1, phase 2 studies, but none of the phase 3 studies have shown. We had the ROSAL and CHISEL, which were initially contemplated as the trials which were going to answer the question regarding surgery versus SABR, but they obviously could not finish accrual and had to be terminated earlier. But their pooled analysis showed that SABR is up to mark and probably non-inferior to surgery. Next, please. So this is something which has just recently been published, probably not even a year ahead, which was the updated STARS cohort, which showed that they had non-inferior results in comparison to surgery. So they did a cohort study. So they prospectively followed the STARS cohort and added more patients in the SABR arm and compared it with the VATS cohort. So obviously this is not randomized. This is not something which we can consider, but given the kind of evidences we had, this is something which is at best the most reliable evidence. Next, please. So it's a single arm prospective protocol, cohort-based study. Their propensity, a pre-specified propensity score matching was done. What is different from other propensity score matching data is that it's a prospectively followed propensity score matching. So therefore, it has a little higher weightage. Next. So they showed that it was designed to test a 3-year non-inferiority in terms of OS, and it achieved that. So they had similar OS, PFS, as well as distance spread and cancer-specific survival. What was higher was the regional recurrence, which was noted in the SABR group. This could be also possible because, their EBUS staging was probably not very accurate, and this translated into higher regional recurrences, which was salvaged. So, and that is probably the reason that OS did not differ in either of the arms. Next, please. We have now something which is very difficult for all of us oncologists, managing central lung tumors and ultra-central lung tumors. And with the advancement of radiation techniques, we've seen that the acceptable toxicity rates with 3 years. So we are moving towards probably managing patients with central lung tumors as well. Ultra central lung tumors, which are probably just abutting the central line mediastinal structures or probably abutting the trachea primarily, which causes a lot of problem. And the toxicity rates in terms of grade 4 and 5 hemorrhage increases as high as 46% in this. And next, please. So this is both the trials which are suggesting that doing these kinds of SABR techniques in ultra central lung tumors is probably not, if you can do it, but with very high risk procedure. And for central lung tumors, it's doable completely. And as my previous speaker was also suggesting that, there's a lot of data that has been coming up with immunotherapy, and we need to assess what's the impact of SABR along with immunotherapy in early lung tumors. And there have been a lot of preclinical studies, and this is one of them. This is just published in, a month back, which has shown that with ablative radiation doses in stage 1, there is systemic T-cell response. And why is it important? I'm not talking about the abscopal effect. We all know that doesn't work. But what is important is that the T-cell response, it continues still up to 3 months and 6 months. So what this study is suggesting that even if with 3 months, you have a PET scan, which is probably showing somewhat of a partial response, and you've taken a biopsy and it still shows viable tumor cells, you don't need to act on it. You probably can wait another 3 months, given that there is no radiological progression and you can manage this with these patients. And this is exactly what this data is suggesting. Next, please. So again, this is something which was derived from the 2018 data from the first data of 235 RTOG trial, which showed that the long-term data which suggested that the distant dissemination was up to 30% with an SBRT local control of 90%. So something now that we have to look into account is patients which are being treated with SABR have distant failures rather than local failures, and probably adding immunotherapy. As we all know, conventional chemotherapy is something patients which do not tolerate well. For already patients who are medically inoperable, comorbidities are high, and we are not able to give conventional chemotherapies. Those patients, maybe immunotherapy adding to SABR might have these, might control these distant failures as well. Next. So this is one of our data. We've done a pooled analysis of all the immunotherapy patients given in lung cancers. Obviously, these had early advanced, locally advanced, as well as metastatic disease. What is important is we did a waterfall analysis for patients who had received radiation prior to or during immunotherapy. And as you can, 37% of the patients had radiation given prior to or during immunotherapy. So there are a good chunk of patients that had been received that. And we did subset analysis for these. Next, please. So next, yeah. So if you can see, this is the univariate analysis of all the patients that we've seen, and this has been published in the Immunotherapy Journal. And there is significant, giving radiation, probably thoracic radiation, in patients who have or before receiving immunotherapy or during immunotherapy. Those have, giving radiation acts as a good prognostic factor. And the analysis, it was significant. So this is something that we need to look. The median PFS was starkly different. It was probably 7.7 months versus 2.5 months, given this is a retrospective data, but something which is very interesting and underlines the importance of immunotherapy and SABR combination effects. Next, please. This was also substantiated with a multivariate analysis. So we did a multivariate analysis using these factors in PFS. And as you can see, even in the multivariable analysis, it was highly significant and had a better survival for patients who had received radiation in any form for immunotherapy. Obviously, this does not per se answer the question whether adding immunotherapy in early lung tumors along with SABR gives you better survival or not. We have to wait for next, please. The three major data that are coming across from Pacific 4 and Keynote 867, as well as the other trial in the phase 3 trial, which is suggesting adding atezo along with SBRT. So these three trials are purportedly supposed to complete their, present their interim data by another, I think, 2 years or 3 years. Let's hope they give us an answer as to whether combining immunotherapy with SABR in early lung tumors has a better survival or not. Next. So the question still remains, let's say, for example, with this, the paucity of data for medically operable patients, and we know that we don't have a direct evidence or a level 1 evidence to suggest SABR, but what are the conditions where would you want to give SABR irrespective of it being medically operable is, if there is, next please, and these are the three core, these are the 5 core issues which are pertaining, and that is the, can you go to the previous slide, please? Yeah, so when doing a preoperative histology is probably counterintuitive to the patient, where patient is not able to tolerate a histology, pathological procedure, or doing a biopsy is something is too hazardous for the patient or has a higher morbidity, as well as in patients who where patients are, patients are refusing to do any kind of biopsy. Even in those patients, it is seen that going ahead and doing a SABR for pathologically unproven patients is beneficial, and the need could, the benefits of SABR outweigh the risk of doing a biopsy in these patients. Next. Obviously, there has been a lot of data regarding patient preference, and we need to incorporate the, the third element and the most important element of oncological management is the patient preference. We need to keep that on table and understand what the patient wants. And there has been a lot of data and the patient-related outcomes and studies regarding what they want and how they want to. I'm not suggesting that you base your evidence on these studies, but definitely these need to be incorporated into your decision making. Next. This is the Scandinavian data, which suggested as to what is happening in their Scandinavian countries as to data, and it's a real world data regarding trend towards SABR. And what they've shown is in all these three countries, the most important Scandinavian and the Danica group, that this incidence of SABR, because they have the pattern of treatment works in a different manner in comparison to the Indian. So all patients are registered under pulmonologist and they refer these patients to the oncologist, whichever the oncologist they want to refer, surgery or radiation, and it has to follow proper channel. So that's how it is blinded. And what they have seen is collection, and this is the data that has been collected over time, that the incidence of SABR is increasing in comparison to surgery, which has been decreasing. It could be both, and obviously this is a population-based survey, so we don't know whether this includes just medically operable or inoperable. What is the comorbidity rate? What is the staging? We don't know. I mean, this is just a trend data. Next. So what we know as of now is that there are no RCTs comparing surgeries, or at least a phase 3 RCT comparing surgery versus SABR. We need to wait for SABR-2 stablemates to answer those questions. We have meta-analysis, we have propensity scores, which have suggested that they are probably at best non-inferior. And all-cause mortality was higher for SABR, but this could be because of the bias distribution at baseline. And in studies, survival endpoints were associated with the propensity score matching caliper distance and first ortho specialty. So this has come out to be whoever publishes the first data in terms of, whoever publishes in terms of specialty, that's how the survival endpoints vary. So what they're trying to say is, it's a surgical oncologist presenting a data, it may favor a surgical oncology survival endpoint. Vis-a-vis, if a radiation oncologist presents a data, then the other way around, that the data might skew towards radiation oncology benefit. So this is something that happens. And despite reluctance, both survival and toxicity data arising for stable and operable lung tumors is probably what we have the answer right now. It's somewhat non-similar, but again, yes, we don't have a level 1 evidence to answer that. Next, please. So this is one of the patient that I've taken up that we've treated. And the only reason that I'm presenting is not that because SABR has a complete response. So we treated this patient on a Videtic et al. Protocol with 54 brain, 3 fractions, and ideal patients. And so as you can see, this is a 4-month PET scan. So this patient got a little late. And the PET scan, in comparison to the previous, showed somewhat MDG activity and a radiological disease response. I couldn't have the next PET scan because the images I couldn't have. But what is important is over the period of time, this FDG activity resolved. So my point of showing this patient was that you need to wait. Don't base your answers or don't base your recurrence definitions on an early SABR PET scan. You can wait up to 6 months to actually label a patient with recurrence or a /residual. This obviously has to be taken in, the radiological progression has to be taken into account. Whether there is is there an increase in radiological disease in both an AP diameter, or is there an increase in the craniocaudal directions also? Mostly what we have seen is that a radiological disease, which is just increasing in the AP diameter, may not be very highly correlating towards disease progression, but whereas a disease which is increasing in craniocaudal direction is probably more likely to be a recurrence or /residual. And obviously there's a pattern of speculations, and a radiologist would always be better to tell you that, but there is definitions regarding recurrence. So do not be hastily label a patient as a residual /recurrent post SABR. Next, please. So this is another patient that we've treated, and we waited for 3 months and then 6 months to say that the disease response, and we quantified the disease response accordingly. And these patients had a complete response on biopsy as well post that. Next, please. Next slide, please. Yeah, so this is my last slide. And this is something which we had presented also, suggesting that you wait for the response and at 6 months PET-CT, even though with a I mean, a CT scan showing some kind of consolidations. The PET did not show any disease, and which was consolidated with, and which was even proven with your biopsy. Next. Thank you so much and giving me this option to present my views, and I'm open to any questions if anybody has them.
Yeah, thank you, Dr. Sarthak, for this wonderful presentation. So 2 or 3 comments, probably because of the recent inclusion of neoadjuvant immunotherapy in the early or resectable tumors and lung. So the things might change further. And we know that there is a school of thought that adding immunotherapy with radiation gives a wonderful effect, because radiation tends to induce new antigens and release the T cells. So the therapy effect increases. So that is the school of thought behind it. So otherwise, the comparison, we might not see a direct comparison between radiation versus surgery. And definitely the things are changing moving forward with the immunotherapy. Maybe we might see surgery being omitted totally in case the diseases are responding beautifully. That may be a way forward. So thank you for your wonderful talk and insight about the radiation.
Just one question I wanted. You are treating SPN with radiation without biopsy? So, I mean,
no, sir, no, this is no. This is not, sir. This is not a statement which is a blanket statement or probably sacrosanct. I'm saying in SPN where you're not able to do a biopsy or patient refuses to get a biopsy done, in those patients it will be very difficult. I mean, SABR, the benefits of doing SABR without a biopsy outweighs doing a biopsy.
Because
so
in
and
India,
this is obviously this is also.
In India, it is 90% tuberculosis and sarcoidosis rather than.
So this is also not. This is also not.
This statement.
No. So this is also not based on your one scan SPNs. You always monitor your SPNs into serial monitoring. So if there is radiological progression on your SPNs, that's the time that you intervene without doing a biopsy.
Okay.
I mean, yeah.
But again, I feel that might be a medical legal issue also doing a
but you have to explain. I mean, there's a lot of data to suggest that. We'll also have to look into account that if the SPN is increasing on your serial scans and you've done an LDCT, and that's what the LDCT trial showed that as well. So if you keep on doing that and you suggest and you feel that this is growing without doing, yes, India has a lot of tuberculosis, but that's what I'm saying. This is not something which is a go-to statement. This is something which you do as an exclusion parameter, that you do not have any other options, and that's the time that you can do and save other patients.
Right. Thank you. Thank you, Dr. Sarthak, for this talk. And next, I invite our chairperson, dear Brigadier Dr. Rajeshwar Singh sir. He's a Director, Medical Oncology Services at Paras Hospital, Panchkula. So, sir would like to, I would request sir to invite his speaker. So it will be Dr. I'll just call upon the name, Dr. Sandeep Kukkad, sir. So, sir, Rajeshwar, sir, over to you.
Yeah, thank you very much, Dr. Nitish. This next topic is very interesting. You know, we are all going towards only chemotherapies in certain diseases, and we are probably going towards rectal cancer, and now we are going towards after the metastatic setting. So much things have been done in as far as immuno and targeted therapies. Now we are going towards early stage of lung cancer also. So in this context, we have with us Dr. Sandeep Kukkad from Sohana Hospital. He is HOD there. He'll be talking about current role of adjuvant targeted therapy in non-small cell lung cancer. Dr. Sandeep, please.
Thank you, Dr. Rajeshwar sir, for the invite, and thank you, Dr. Nitish, for providing the opportunity. Let me share my screen first. So the slides are visible, I hope so. The slides are visible?
Yeah, visible.
Yes.
They're moving?
Yeah.
So let me start the current topic with The patients who actually undergo lung surgery, the proportion is very less. Approximately 20% of population in India, they present with a disease which is actually resectable disease. And for decades, we had only the doublet-based, cisplatin-based chemotherapy, which is actually recommended post stage 2 or stage 1B onwards. And they have a minimal impact in improving the overall survival as well as in decreasing the risk of disease recurrence. So in absolute terms, the cisplatin-based therapy is associated with only 16% decrease in the risk of recurrence at 5 years, and an absolute improvement in the survival is approximately 5 years at the end of 5% at the end of 5 years.
Dr.
So
Sandeep, your slides, this is first slide only?
Yes, Dr. Saab, this is first slide. So this is just the beginning that I wanted to make a statement that since decades, we did not have any other option apart from chemotherapy, and till now we have been using the same. So if you look at the data from 1971 to 2011, you can see the lung cancer is at the bottom of the list, where the improvement in survival has not been that great if you compare other cancers. So again, the median survival, if you look at whether we had used a single agent platinum-based therapy, doublet, third generation, there came the era of histology that matters, and then came the immunotherapy. So overall, over a period of last 4 decades, there have been a consistent improvement in survival depending on what we have chosen as a baseline, like whether it is histology, whether it is the molecular testing, or nowadays we have the PD-L1 for selection of treatment for our patients. So the challenge in lung cancer remains that the patient presents late. So that is why approximately 20% of the patients are resectable. Majority have a metastatic spread. Improvement in therapy with advanced disease has a limited impact on 5-year survival. There are very low percentages that are resectable, and the 5-year rates, they depend on stage, but even in early stages, the risk of recurrence it is always there. So you can see here the 5-year survival according to stages 1A, 1B, 2A, 2B, 3A, and 3A and 3B. So the 5-year survivals have been, the rates have been dismal. They range from approximately 70% to 20%. Majority of the patients have a distant spread of the disease. And if they present even in the early stages, the micro dissemination is a major problem. That is why 80% of the relapses, they occur within the first 2 years of surgery. So this was the first trial that I would like to start with, how the chemotherapy has evolved over a period of time. This was the first trial that was IALT, where stage 1 to stage 3 patients, this was the number of patients were very high, approximately 1,800 patients. Stage 1 to stage 3, where 36% was stage 1. Cisplatin-based therapy was given. At the 5-year survival, you can see here the absolute benefit was only 4% at the end of 5 years. So then came the JBR-10, which actually established the role of cisplatin and vinorelbine versus no chemotherapy, and the absolute benefit was around 15% at the end of 5 years. So this trial not only demonstrated the survival benefit, but also commented upon the use of chemotherapy only in selected stages, like survival benefit was seen for stage 2 onwards. So we came to a conclusion that there might be a subset of patients in stage 1 who might get away without chemotherapy. So CALGB 9633 again used a different regimen approach like paclitaxel and carboplatin, and again the benefit was between 10 to 15%, 12% at 4 years, and no significant benefit at 5 years. So this again commented upon the tumor size, which is in stage 1B. Nowadays we look at, that is, if the tumor size is more than 4 centimeters, the patients are eligible. So the size of the tumor makes a difference even if it is an early stage disease. So if you torture the data long enough, it will confess to everything. So that is what we have seen in many of these studies. So then came the landmark ANITA trial, where 840 patients were subjected to cisplatin, where patients used a cisplatin and vinorelbine based approach for 4 cycles compared to an observation. Again, the similar consistent results were seen, approximately 8% of benefit at 5 years. And the survival benefit majority was seen in patients those who were node positive, that is N1 and N2, and not in the node negative. So these trials have made us believe that there are several factors, not even the one factor. One of it is stage, one of it is the nodal involvement, the size of the tumor. So there are several factors if you are choosing the adjuvant therapy in an early stage lung cancer. So this was a Pignon meta-analysis published in JCO way back in 2008, LACE meta-analysis, which demonstrated this actually included the 5 largest trials that I have included so far, and they commented upon that the trend was worse for stage 1A, which can get away without chemotherapy. Hazards for stage 1A and 1B, they were approaching either 1 or more than 1. And the benefit was seen in stage 2 and stage 3. And this learning has been there since last almost 2 decades. So chemotherapy effect has been there with different stages, and the benefit you can see in stage 1, the 5-year benefit is approximately 2%. Stage 2, the 5-year benefit is approximately 11%. And the maximum benefit with stage 3 is 14.7%. So the evidence has now become the conclusion of majority of the trials after a decade of 3 decades of research. That is, I have already stated in the bar diagram that these trials and the meta-analysis has conclusively made a statement that the adjuvant chemotherapy makes a benefit in lowering down the risk of recurrence, as well as bringing an improvement in overall survival to the tune of around 5 to 10%. So what are the patients where now we are coming to more and more number of patients, that what could be the patients where you can use an absolute chemotherapy based approach, or you can target your patients, as now the trend is to test each and every patient for a NGS for various mutations that are seen in lung cancer. So what are the ideal candidates who can be given chemotherapy? And apart from chemotherapy, what are the candidates where one would offer beyond chemotherapy, that is either the use of TKIs, EGFR inhibitors, or an immunotherapy based approach as we now see. So the challenge has been there because the staging system has changed, the TNM staging has been changed. There has been no consistent consensus about stage 1A, and every single trial has stated that for stage 1A, one does not need chemotherapy. Chemotherapy is actually indicated for stage 1B onwards, and definitely for stage 2 and stage 3. For 1B, there one looks at the high-risk features like lymphovascular invasion, poor differentiation, high SUV proposed, but there has been no consensus about the SUV in PET-CT scan. So another area of debate has been the use of adjuvant chemotherapy in the elderly patients. So again, the underrepresentation of this subgroup has always been a problem, and we don't know whether this particular age group would, once was subjected to the adjuvant 4 or 6 cycles of chemotherapy, there would be some survival benefit, and how long it would be beyond 75 years, we don't know. So that is why we are able to only extrapolate the data that we have learned from the ANITA, the LACE analysis, and the several other trials, which have conclusively made a statement that the adjuvant chemotherapy helps in all. So again, the toxicity, we all know the general chemotherapy related toxicities, that is neutropenia, febrile neutropenia, thrombocytopenia, peripheral neuropathies, and emesis. Choice of regimen. So I think cisplatin and vinorelbine is the most studied regimen and the most commonly used regimen. Nowadays, cisplatin, etoposide, or paclitaxel all have been used, and each regimen has proven to have similar OS results, but they are underpowered to detect certain differences. So the timing beyond surgery is approximately 6 to 8 weeks. So the various trials have used a different cutoff, but approximately around 6 to 8 weeks has been the cutoff beyond which one should start the adjuvant chemotherapy. So the ESMO guidelines, again, there are several factors apart from the stage that I have already stated, and even in the elderly patients, one can extrapolate the same data. The ESMO guidelines have again revealed the same, that one can use a doublet chemotherapy depending on the comorbidities of the patient and the availability of local drugs. But now comes an important context, because as we have evolved from the era of only a blanket treatment of patients with chemotherapy, now we are targeting each and every patient with an NGS-based approach. We have been testing each and every patient for EGFR, the ALK, and ROS in the advanced stages, but now the consensus has been to test these patients for EGFR and ALK mutations in the adjuvant settings as well. So the earlier trials before the origin of the ADAURA trial, several first generation and second generation EGFR TKIs have been used, like SELECT trial, RADIANT trial, EVAN trial, adjuvant CTONG trial, BR119, but they have used different strategies, but none had been proven so far to lead us to a DFS or an improvement in the overall survival benefit. So then came the era of osimertinib. So how osimertinib is different apart from all these first generation and second generation? We all know that this is a third generation EGFR TKI, which actually inhibits the EGFR TKI as well as the T790M MET resistant mutations, and has got an excellent penetration in the CNS as well. So again, the FLAURA was the first study that actually revealed us that this drug actually works wonders in the metastatic settings and the advanced settings. But now we have the origin of this trial in the adjuvant settings in the early stage resectable breast cancer. So this was the paper that was published in New England Journal of Medicine way back in around 2020. Now this has been around 3-4 years. So osimertinib was tested head on. So how after the resection, osimertinib versus placebo, the primary endpoints were DFS for stage 2 and stage 3 that we all know, and secondary endpoint was for overall population and the overall survival as well. So again, you can see here the curves are very well separating. A total of 682 patients, they underwent randomization. So at the end of 2 years, 90% of the patients with stage 2 and stage 3, which was the primary endpoint in osimertinib group, versus 44% in the placebo group. There is a huge difference in between the Kaplan-Meier curves. And the hazards were very, very impressive, 0.17. So now you can see here, even in patients who had where you wanted a CNS relapse-free survival, the benefit was absolutely there. So you can see 98% versus 85% alive without a CNS disease. So the drug has been very, very impressive because of its significant properties being a third generation TKI. So you can see here again, the previous trials have failed, but even in the patients who had a stage 1B to stage 3A CN, this was a recent 2023 update where there was an improvement in CNS DFS as well according to the different stages. So the CNS relapses are very common with EGFR mutated populations, and osimertinib is one of the potent agents that has a very good blood-brain barrier penetration, which actually leads to decreased recurrences in the CNS. So osimertinib should be the standard of care versus it should not be. There are several pros and cons. ADAURA improved the DFS across the subgroups and populations. Only 11% of the population actually stopped it because of adverse effects. There was a remarkable reduction in the CNS metastasis. It improved the DFS, reduced brain mets, clinically worthwhile. Cost benefit has always been a concern for the Indian population. So what cons? Using DFS as a surrogate for OS is not validated in the targeted therapy. No OS benefit for the adjuvant first generation TKI. So ADAURA aim of adjuvant is to improve the OS. So there was I don't know how relevant it is, whether it was to choose DFS or the OS in the resectable population. So there have been several debates over one should use osimertinib as a standard of care in the early stage EGFR mutated populations. So again, ESMO clinical guidelines, they clearly stated the patients who have gone a complete tumor resection in adult patients with stage 1B onwards with a EGFR mutated, whether it is DEL19 or exon L858R, should be treated with osimertinib. So now we come on to the recent topic that has been over the hotline for last 1 to 2 years, whether to use pembrolizumab versus a placebo as adjuvant therapy for completely resected 1B or 3A NSCLC. So this was a keynote trial, an interim analysis of a phase 3 that was published in Lancet in 2022, around 1 year back. So this was a Pearl-CTOP study, phase 3 data with pembrolizumab. So the patients received actually adjuvant chemotherapy, and then they were randomized to receive pembrolizumab versus placebo. So you can see here, this trial was conducted in 29 countries with 196 medical centers. So again, the staging we all know 1B onwards, and adjuvant chemotherapy was considered for around 1 year. So the final conclusions were that pembrolizumab significantly improved the disease-free survival compared to placebo and was not associated with any new safety signals. Pembrolizumab is potentially a new treatment option for patients with stage 1B and stage 3A onwards who have undergone complete resection, regardless of the PD-L1 expression. Excuse me. This was again another data that was published 2 years back with atezolizumab. The similar kind of data with adjuvant atezolizumab, that is IM power 010, stage 3, stage 1B onwards to stage 3A phase 3 trial, which actually compared atezolizumab versus best supportive care. Similar kind of conclusions you can draw from what we have seen from Keynote trial. That is, almost 1,269 patients has received adjuvant chemotherapy. Approximately 1,000 patients were randomized. And at the end of the day, if you see, the conclusions were that even in patients who had a PD-L1 expression of more than 1%, there was an improvement in the disease-free survival. So these are several data which have been published so far, which have led us beyond the use of adjuvant chemotherapy of a platinum doublet-based approach, whether it is the use of osimertinib or the use of immunotherapy, Keytruda or atezolizumab in population who have received adjuvant chemotherapy in stages 1B to 3A onwards. So that is all I have. And the final conclusions are adjuvant chemotherapy is established for 1B, stage 2 and stage 3. 1B can be considered for adjuvant chemotherapy if the tumor size is more than 4 centimeters. Selected older patients who are able to tolerate chemotherapy with acceptable toxicity can be given. Adjuvant osimertinib improves the DFS and reduces the CNS relapse in EGFR, DEL19 or L858R, and the addition of adjuvant immunotherapy in patients, those who do not have these mutations, leads to an improvement in DFS. So thank you all for patient hearing, and if there are any questions, I'll be happy to answer.
Thank you, Dr. Sandeep. That was a lovely presentation of the gamut of treatment outcomes in a early stage lung cancer, right from chemotherapy to this targeted therapy. Just for information that the ADAURA trial overall survival has been published in abstract form with the hazard ratio of 0.49. So that again shows that such a lovely response this drug has. And secondly, this new adjuvant and adjuvant is becoming a very, very obscure which drug to give and which drug not to give. Though I personally prefer, because that got new adjuvant followed by adjuvant in a CheckMate nivolumab trial. So we have to go through this now because we have so many options. We do not know what to do. Though we don't get this sort of patient, it is generally for discussions only. I hardly see, probably PGI Sync because the numbers are large. I hardly see any patient in this setting. So very nice presentation. Any other questions if somebody's got? Yeah.
So do we see a lot of patients or do we prefer to give a neoadjuvant chemotherapy form of treatment in a resectable lung cancer? Because there have been some phase 2 data, and even there have been trials from Rajiv Gandhi where they have been trying to give neoadjuvant treatment, make it more resectable, followed with the adjuvant radiation and.
Absolutely, the CheckMate trial has they published a CheckMate trial with nivolumab with such a good responses they have. In fact, they are saying that immunotherapy is much better in an early stage because tumor mutations and something are not that much as compared to in a metastatic setting. So now immunotherapy is coming in a big way, and the CheckMate trial has come with nivolumab is showing wonderful results in this.
So without immunotherapy, we can continue using neoadjuvant chemotherapy in the settings. That will be, I believe, a selected number of cases where we are planning that yes, it is a borderline resectable disease as per the mediastinoscopy findings and the size of the disease, and we give them neoadjuvant chemotherapy. Not if a patient is not affordable for immunotherapy, because as the surgeon says, post immunotherapy the surgery can become a little difficult because of increased fibrosis.
You see, we can only do in stage 1, 2, and 3 because standard of care in 3B and above is chemo-RT. So we cannot fiddle with the standard of care because unless some trial comes which compares with the standard of care. In a early stage, these are the trials which are there. Otherwise, giving chemo, and because patient is not going to tolerate after chemo, surgery become very difficult to thereafter, and vice versa. Immunotherapy tolerance is little because I have seen couple of patients what we have seen, it becomes very difficult after chemotherapy surgery and thereafter if there is some positivity margin is there or something, very difficult to treat that patient for it.
Right.
Okay, thank you very much, Dr. Sandeep, and we proceed on to the next topic, which is the role of molecular testing in carcinoma lung. This will be given by Dr. Surushi Agarwal from Bangalore. Dr. Agarwal, please.
Hi, good evening all. Thank you, Dr. Nitish.
Sandeep, can you unshare, please? Unshare your slide.
Just a moment.
I'll share my screen.
Okay now?
Yes. Is my screen visible?
Yes, ma'am.
Full screen, kindly do it full screen.
Yeah, I'm doing that. Is it okay now?
Fine. Yeah.
Okay. Yeah. So thank you, Dr. Nitish, for this opportunity. So am I audible, loud and clear?
Absolutely.
Yes.
Thank you so much. So today I'll be talking about role of molecular testing in lung cancer. And as we all know that lung cancer is the most, it is the only cancer where we have most targetable biomarkers. And as you can see, we all are aware of this timeline, 1977, when EGFR was identified, it was a breakthrough. And since then, we have a lot of first line, second line, third line EGFR TKIs been approved. And we are right now, even for exon 20 insertion, which is a rare mutation in EGFR, still we have the drug approved. And there are ongoing trials for other uncommon mutations in EGFR. So basically for uncommon or non-classical EGFR mutations, afatinib has also showed a good response and was granted FDA approval based on some trials. And osimertinib has also shown favorable activity with manageable toxicity in patients with metastatic or recurrent non-small cell lung cancer, which harbors uncommon EGFR mutations. So what I want to start off with is that there are multiple types of molecular biomarkers which can be targeted in lung cancer, and EGFR being most common. There are certain driver mutations, common mutations, which are very well known, and there are a lot of uncommon mutations also which EGFR harbors, and TKIs can respond in different way, the way the mutations are present. Like they can be compound mutations, they can be uncommon plus common, common plus uncommon. We'll be looking at it in further slides. So this is the trial which is ongoing for rare mutations, which includes EGFR uncommon mutations like 719 and 768, for which we do not have drugs right now. EGFR exon 20 mutations, HER2 exon 20 mutations are also included as inclusion criteria in this trial. So this slide gives an overview of oncogenic drivers in non-small cell lung cancer, like we have most importantly EGFR, KRAS, other genes, then BRAF, ERBB2, MET, ALK fusion, ROS1 fusion, RET, MET amplification, HER2 amplification, NRAS, HRAS, and to name a few. And most of these molecular biomarkers or genes, they have targeted therapies available. So it becomes very important to test for them when we are looking at a lung cancer patient. And then to show that what is the percentage of uncommon mutations shown in this orange color, you can see this is a study from, this is a data from about 14 studies. So from France, you can see 18 point of total EGFR mutations were found to be uncommon mutations. Similarly, from Brazil, 18, Taiwan, 16, China, 15. So we have a lot of uncommon mutations in EGFR that occurs, and we need to look at them with care. And here you can see some of the uncommon mutations which have been highlighted in exon 18, 19, 20, and 21. So there are a number of uncommon mutations which can, play a different role how TKIs respond. So this is what I was talking about. Like uncommon mutations are not only uncommon, but they can be compound as well. They can occur with one of the common mutation. They can occur as uncommon plus uncommon, or any mutation with de novo resistance mutation, which is a very well known T790M resistance mutations in about 10 to 50% of cases. This is another piece of data published recently in literature, in Nature paper, where they have shown structure-based classification. So based on the position of drug binding pocket, or different structures, domains in EGFR protein like P-loop, alpha-C helix, hinge, or hydrophobic core, and how the drug binding pocket is arranged. And these mutations, the position of these mutations, they have been classified into 4 categories, like classical-like, exon 20 loop insertion, T790M-like, and P-loop, alpha-C helix, PAC compressing mutations. And here you can see the drug selectivity differs based on the category of the mutation, which are categorized based on the position of drug binding pocket. So red one indicates that this is resistant to this mutation, or 3rd generation, 2nd generation, 1st generation TKIs can be administered. Similarly, here you can see with very less options that here 2nd generation, 1st generation can be given, here 3rd generation can be given. So not only we should look at what driver mutation is present in EGFR, but what other mutations are occurring along with EGFR, both common and uncommon, or classical or non-classical mutations are important when we are selecting the therapy. And these are other rare events like AL-Cross1 fusions with unknown partners or atypical transcripts, MET exon 14 skipping events resulting from non-canonical deep intronic changes at DNA level, which is difficult to find at DNA level, but can be easily picked up at RNA sequencing level. And then resistance mutations in EGFR, AL-Cross1, RET, some compound mutations which occur in concurrent with other mutations, and co-occurring mutations in STK11 and KEAP1 gene is also coming up in literature as one of the resistance mechanisms to EGFR TKIs. KRAS G12C with poor prognosis in response to immunotherapy or immune checkpoint inhibitors. And these are some of other resistance mutations which are rarely reported but are important to understand from that individual patient point of view. MET amplification, RET rearrangements, NTRK rearrangements, BRAF rearrangements, and activation of other pathways like PIK3CA. Not only uncommon mutations, but concurrent mutations in other genes along with EGFR, like EGFR plus TP53 co-mutation, or EGFR plus PIK3CA, PTEN co-mutations, or other biomarkers like PDL1 high along with EGFR mutation. So these scenarios are also reported and has to be looked upon carefully when selecting the treatment. So then what our molecular diagnostic workflow should be to include all the biomarkers or all the important biomarkers so that we can be holistic in our therapeutic approach. So option A, which is I think being now adopted by most of the clinicians, is that PDL1 IHC plus broad NGS panel, including most of the targets, druggable targets that are present in NCCN guidelines or standard guidelines. And then if it is negative or in advanced settings, then other comprehensive genomic profiling to understand TMB, MSI, and other tumor agnostic biomarkers. And then option B, which was earlier used, was like PDL1 IHC followed by single gene PCR assays, and then ALK IHC, ROS1 IHC, and TRK IHC is now being done, RET, FISH, or RT-PCR to see one by one cascade or parallelly different biomarkers. But now, since we have next generation sequencing based testing, so all the biomarkers can be included in one single test, and it is cost effective as well as time saving. NCCN guidelines also recommend broad panel tests, including RNA-based detection for optimal fusion detection. Now, this is very important point, that for fusion detection through NGS, RNA sequencing plays an important role, which we will be discussing in further slides, how RNA-based sequencing for fusion detection is better than DNA-based sequencing. RT-PCR gives us limited approach, limited biomarkers can be tested. And FISH should be used as a confirmatory test for copy number variations, because NGS has limited sensitivity for copy number variations. And wherever tissue is not available or has failed next generation sequencing, or it is the rebiopsy is not possible, in those cases, liquid biopsy should be used as a reliable approach or an alternative to tissue biopsy, so that biomarkers can be identified. And ideally, complementary testing, tissue plus liquid, should be done to get the complete biomarker profile. So before going to the cases or specific tests, I would like to show some of the, this is a IGV snapshot of a patient sample, sequenced sample, where T790M resistance mutation, this is the mutation which is showing as a change as compared to the reference DNA, and C797S also as a change here as compared to the reference DNA. Since they are proximal, so they can be visualized in one single view of, this is integrative genomic viewer, and these blue and pink bars, they represent the sequence that we have got, or the reads that we have got after next generation sequencing. So basically this concept is to show that if they occur in the same read of the sequence, then they are in cis position. And if they occur in different reads, then they are in trans. So that means if they are in cis, they are derived from the same clone. If they are in trans, the clones are different. So as we know that these are the two resistance mechanisms which can occur concurrently, and they can be either in the cis form or they can be either in the trans form. So next generation sequencing based testing can help us to understand whether these two mutations, first of all, are present together or not. If they are present together in a single sample, then are they in cis or are they in trans form? So NGS report will have this information. And this information is very important to understand the therapeutic approach, because if they are in trans, the cells will be resistant to third generation EGFR TKIs, but they will be sensitive to a combination of first and third generation TKIs. So, and if they are in cis, then the therapeutic approach will be different. So therefore, next generation sequencing based technique gives us this information of cis and trans for these resistance mechanisms. Another important information that we get from next generation sequencing is about MET exon 14 skipping mutations, which are present in 3 to 4% of lung cancer patients. And they also occur as a resistance mechanism. Usually MET amplification is a resistance mechanism, but 3 to 4% of cases, they exhibit MET exon 14 mutation. And what happens is the mutation at DNA level in MET exon 12, 13, 14 or proximal introns, it results in the skipping of exon 14. So if you see here, when we do RNA sequencing, we can actually look at the expression of exons. So in control sample, expression of exon 14 is there as compared to the other exons. It is comparable to other exons. But in sample of interest, where there was a DNA mutation, which is a splice mutation encompassing the exon and intron, the exon 14 is skipped. Means there is no expression of exon 14 here as compared to the other proximal exons. So therefore, DNA plus RNA based approach is very important to understand the effect of mutation that is happening at DNA level, whether it is translating or transcribing at RNA level as well. So this gives us a fair idea that yes, metexon 14 mutation that is present at DNA level has actually resulted in skipping of exon 14. So this information also we can get through next generation sequencing, which involves RNA and DNA sequencing. So these are the panels which are available, like it can vary from 9, 12, 18 genes, depending on the size of the multi-gene panel that we can look at. And now 18 gene panel is coming up where PIK3CA, KEAP1 and STK11 genes are included, apart from other druggable targets that are present. FGFR3 is also TP53. These genes are also included, and NTRK fusions, they are considered as tumor agnostic biomarkers. So they are included in the panel. CNVs for ERBB2, MET, KRAS, EGFR, and fusions for ALK, ROS, RET, NTRK, NTRK2, 3, 4, FGFR3 is included in this panel. So if we look at one case of a female, 55-year-old female, she was diagnosed with non-small cell lung adenocarcinoma, and the panel, NGS panel was performed. And as you can see, when we perform NGS panel, we can get multiple mutations in the same gene also. And here we got exon 20 insertion in HER2 gene at 23.5%, and classical 776 codon mutation at 27.2% in this particular patient. And if we would have only done EGFR by RT-PCR or ALK-ROS IHC, we would have missed this important target, which has multiple drugs in clinical trials as well as approved drug. So this is what I was talking about, that RNA-seq fusion detection and DNA-seq based fusion detection. So when we do RNA-seq based fusion detection, basically fusion happens at DNA level when gene A or EML4 is getting fused to ALK, for example. So the breakpoints can occur in introns. And when they are spliced at RNA level, only exons are fused. So if EML4 is fusing with ALK at RNA level, we can detect it by only using exonic probes. However, if we have to identify it at DNA level, we have to also include intronic probes. Introns are quite large sequences which spans exons. Therefore, the panel size becomes very high, and therefore the cost of sequencing also becomes high. And it is impossible to include all the introns in the panel design when we are doing targeted sequencing. So fusion detection by RNA-seq is, we can pick up any partner to ALK, not only EML4, but we can pick up any partner to ALK, because exonic probes can detect exon-exon fusions. So when we did RNA-based fusion detection for a patient, we could detect SLC34A2 ROS1 fusion. However, there was a DNA-based fusion detection test also done for the same patient, but this fusion was not picked up. So when we looked at the breakpoints here at RNA level, we found out that the breakpoints were not so usual. So if the breakpoints are not common and not included in our panel for DNA sequencing based fusion detection, it can miss. So similar concept also occurs with when we do fusion detection by liquid biopsy, because liquid biopsy uses only circulating free DNA. It cannot be RNA based. So when we do liquid biopsy based fusion detection, again, DNA sequencing can miss some of the fusion targets as compared to RNA-seq based fusion detection. So when we do tumor biopsy based next generation sequencing test, we have different levels of QC checks, or we have different levels of rejections where the tumor may fail. So first of all, we need to have adequate amount of tumor tissue. So as we have also heard in previous talks that the biopsy, lung biopsy usually is a core biopsy or a true cut biopsy, and the amount of tissue is sometimes insufficient to perform molecular testing, or the depletion of the block has to be done. So in those cases, if the amount of tissue is not sufficient, we cannot perform next generation sequencing based test. And apart from that, we need to have at least 10% tumor cells in the block, that is tumor content or neoplastic cell percentage in the block, to perform next generation sequencing to have a good diagnostic yield. If tumor content is not 10% or less than that, the diagnostic yield may be compromised and we may end up with false negative results. Then after we do these checks and it passes, we have DNA QC level, where the quality and the quantity both matters. And if quality is not good, that is DNA integration number, which may be attributed to fixation artifacts or cold ischemia time or age of the block. So if the DNA quality is not good, then in those cases also we may have compromised library and NGS data. And sometimes we have to reject at DNA level only. However, in our experience for lung cancer, most of the rejections, it happens at tumor content level or amount of tissue. We don't have enough amount of tissue to perform NGS test to achieve this concentration of DNA, or we may not have enough tumor content to proceed with the test. So nonetheless, we have liquid biopsy as an alternative, which is also recommended in guidelines and has been now extensively used, has been now adapted in clinical community as an reliable alternative to tissue biopsy. And here, with the advancement of next generation sequencing techniques, error corrected next generation sequencing techniques like use of UMIs, we can achieve limit of detection of 0.2% variant allele frequency. And we have many advantages also of liquid biopsy over tumor biopsy. Disease monitoring is easy. We don't have to go for rebiopsy. And we can even detect very low frequency variants, because as you can see, the limit of detection has gone down to 0.2% variant allele frequency. And tumor heterogeneity can be captured if there is a metastasis or there are multiple lesions. Tumor biopsy is usually focused. However, liquid biopsy will capture the DNA from all the lesions. So we have well-validated and CAP accredited test and covers fusions as well. So here again, the design has been made to include most common intronic regions so that these fusions are not missed out. And we have done almost more than 250 samples now. This is the data of 140 samples. And you can see in 7 samples, we could pick up ALK, EML4, EZR, ROS1, RET fusion, BRAF fusion, ROS1 fusions. And these were relapsed cases where IHC has already shown ROS1 positive cases, and we picked up the fusion as well as resistance mechanism. I'll show you some of the cases. So this is that case where we picked up CD74 ROS1 fusion. She is a 52-year-old female, and she was found with ROS1 fusion by FISH in 90% of cells in tumor block. She was treated with ROS1 inhibitor, responded well, however relapsed. And when we did liquid biopsy, CD74 ROS1 fusion was identified, plus G2032R. This is a resistance missense mutation in ROS1 gene, which could have contributed to the relapse on ROS1 inhibitor, was also found. Similarly, this case is like one of the first cases when we started doing fusions on liquid biopsy. And here, a patient did not respond to chemotherapy, 50-year-old male, and he was not responding to chemotherapy, presented with massive pleural effusion and was on oxygen. So liquid biopsy test was done and we identified EZR ROS1. On initial blocks, only EGFR was done and EGFR was negative, and blocks were not available for further testing. So EZR ROS1 only by liquid biopsy was identified. Patient is on crizotinib now and responding well. Partial response has been seen in past 6 months of treatment. So to validate our liquid biopsy fusion, specifically fusion test, we sent the same sample to Guardant 360. This was another interesting case where we got tumor biopsy as well as liquid biopsy at the same time. Tumor biopsy identified GCC2 ALK fusion. However, our liquid biopsy test could not identify this fusion. And this is the reason why RNA-based sequencing can identify known unknown partners both. Here again, the breakpoint was unusual breakpoint, which was not included in our liquid biopsy panel. We sent this sample to Guardant as well, and Guardant also couldn't detect the fusion. So basically, this is a very, well-known concept that to detect the fusion at DNA level, we need to include intronic probes. So if that intronic region probe is not there where the breakpoint is there, it will not detect that particular fusion. However, when the panels are designed, whether Guardant or whether MedGenome, most common or the commonest breakpoints which are reported in literature will be are covered, and therefore 90 to 95% of fusions will be covered by liquid biopsy NGS also.
Dr. Surushi, 1 minute now.
Yeah, sure. So I'm just ending it up. Basically, this was another case where 49-year-old male non-smoker presented with lung adenocarcinoma and was EGFR exon 19 del positive. TKI was administered, relapsed in 2023 with brain and bone mets. And as liquid biopsy test was performed, the resistance mutation that was found was ACAP9-BRAF fusion. So BRAF fusions as a resistance mechanism to EGFR TKI is found in only 0.2%, which is rare. So what I want to give a message through these cases or studies is that there is a lot of genetic information which can be missed out when we are doing very focused testing. So these rare cases, however, they are rare in population, but for that particular patient, they may be very important to understand. So key takeaways that EGFR mutations are classical, most of them, 90%. However, there are 20%, about 1 to 20% of EGFR mutations that would be uncommon. And NGS-based broad panel testing approach, which includes RNA-based fusion detection, is recommended as a molecular testing approach. Combination of tests, IHC plus NGS, may be better choice to cover all biomarkers. And liquid biopsy is proving to be a promising tool when tissue biopsy is not available and failed in molecular testing. So these are our some of the tests that we offer. Thank you.
Thank you very much. That was exhaustive presentation for general oncologists. Now I'll call it. It is very difficult to follow all these things unless you're dealing only with respiratory. Any question by anyone? If there is, if no, thank you very much, Dr. Shruti.
Sir, I have a question. So in the lung panel, madam, do we ask for a specific that we need RNA-based testing by NGS, or we can just write NGS there?
So actually most of the labs, we need to check like which lab is offering RNA-based fusion detection when we are prescribing the test. Basically, when the tests are validated and they are offered to you, so it is mentioned that fusion detection is RNA-based or DNA-based. So as per literature also, RNA-based fusion detection is, at least on tumor biopsy, is much more reliable than DNA-based sequencing.
Okay. So
ideally for lung, both DNA plus RNA should be done.
Okay, fine. Thank you.
So why I actually kept it like this is because I wanted to, I didn't want to talk general about all the biomarkers that we all know, because the target audience here knows about all the biomarkers. So I wanted to give some technical concepts like which will help more to choose the lab and the test, like because we have a lot of labs and tests now available, and it is difficult to decide like which lab to go for or which test to go for.
Thank you, Dr. Surushi. Now we proceed on the next topic, role of, that is a first line EGFR in non-small cell lung cancer. Is TKI enough? It will be delivered by Dr. Pooja Babad from Delhi. Dr. Pooja, please.
Hello, everyone. Thank you, Dr. Rajeshwar, sir, for the kind introduction, and Dr. Nitish for giving me this opportunity. So topic of today is first line treatment option in advanced non-small cell lung cancer. Is TKI enough? My slides are moving.
Yeah.
Yeah. So first generation TKI, and we have seen that when first generation TKI were compared with chemotherapy, erlotinib in EURATEC ensure an optimal trial, and geftinib in IPAS Japanese and NEJ002 trial, there was definitely an improvement in progression-free survival with an hazard ratio of 0.34, 0.16, and there was no benefit in overall survival. And as we know, DEL19 as compared to L858R represents a better molecular group with a better progression-free survival. So osimertinib or platinum pemetrexed in EGFR T790 mutation positive lung cancer. As we know, osimertinib has shown, it is the only TKI which has shown an unprecedented improvement in progression-free survival as well as in overall survival, both in first line as well as in second line. So this is a second line trial of osimertinib where it works specifically in EGFR T790 mutation positive lung cancer. And it has shown median progression-free survival of 10 months versus 4 months, and an overall survival benefit of 26 months versus 22 months in second-line therapy as compared to chemotherapy platinum pemetrexed based. Again, the overall survival slide showing hazard ratio of 0.80. And it has shown survival in all the groups except L858R mutation. As we know, this is a subgroup which has more number of co-mutation, almost 70% as compared to 40% in exon 19 deletion, a poor prognostic group. And most of the TKI has not shown OS benefit in this particular subgroup. So Asian versus non-Asian, as we have seen in FLORA trial, especially for an overall survival benefit, in osimertinib, there was no difference between Asian and non-Asian. Whereas in terms of progression-free survival, either in FLORA or AURA trial, there was a benefit. Again, the graphs are depicting exon 19 is way better than exon 21 in terms of survival. Now, first line subsequent therapy, first line osimertinib versus the first generation TKI, we can see that almost 60 to 70% of the patient received the subsequent therapy. Almost 30% of the patient in EGFR TKI received osimertinib. Especially in the FLORA trial, patients who were on first line TKI arm, they were allowed crossover when there was a resistance and there was T790M mutation was detected, and they were allowed to cross over to osimertinib. Despite crossover, there was a apparent benefit in both PFS and OS. And at 3 years, almost 28 to 30% of the patients were on osimertinib versus 9% of the patients were on chemotherapy. And these are all the subgroups which has shown PFS benefit. PFS benefit were seen in all the subgroups, whereas in the OS, the benefit was not seen in L858R mutation as well as in the Asian population. So pros and cons of osimertinib as first line. Definitely, it's a well-tolerated drug with very less dose discontinuation, very less dose modification, and very less grade 3 adverse event. It has shown increased progression-free survival to the tune of 19 months and also increased overall survival to the tune of 38 to 39 months. It is a drug that we all know crosses blood-brain barrier, and it also increased the progression-free survival of emergence of CNS metastasis. Even for the patient who have baseline CNS meds, it prevents the further progression within hazard ratio of 0.47. But then when we expose the patient to the best drug upfront, which is osimertinib, then what do we have at progression? Since we know when the patients are exposed to first line or a second generation TKI, the most common emerging mutation is T790. And then to target that, we have a drug which is osimertinib. But once we give osimertinib, it reduces the amount of or the emergence of EGFR resistance, but quite heterogeneous amount of resistance emerges, like MET amplification, compound mutation, uncommon mutation, exon 20, C797S. So definitely we have limitation in terms of options at progression when we expose patient upfront to osimertinib. Asian subgroup and L858R, as we have seen in overall survival, the benefit is limited and cost is definitely a major issue. So updated overall survival in randomized study comparing dacomitinib with geftinib as first-line treatment in patient with non-small cell lung cancer with EGFR mutation. We have seen Archer 1050 and the median OS is 34 months versus 27 months in geftinib. Now, in this particular second generation TKI, we have seen the benefit with exon 21 L858R was also consistent, like that it was with exon 19 deletion. So the benefit was seen in both the subgroups. Though there was a numerical increment in median overall survival, still statistically it was not significant. The probable reason would be it was in hierarchical statistics, where initially a difference in PFS was required and overall response rate to further proceed to a meaningful statistical significant improvement in overall survival. Since there was no difference in overall response rate between the two arms, so it did not proceed to OS. So I was explaining the same thing. So now what next? So as we know, in today's era, just a first generation or a second generation TKI is not sufficient. And it is because we are increasingly utilizing NGS. We have newer and newer mutations, co-mutations, concurrent mutations, and we know to target these mutations with first generation or second generation TKI, the results are dismal. So now what further option we have? The first option we have seen, that is third generation TKI, which is osimertinib. Now the next option is the combination therapy, TKI with chemotherapy or TKI with anti-VEGF. Is there any rationale? What is the evidence and its level? Is it applicable to all the subgroups? What about the toxicity and cost-benefit analysis? So rationale is definitely present, as we have seen earlier in Japanese study, that there is a synergistic effect when we give this first generation TKI with chemotherapy. There is an enhanced apoptosis of these cancer cells. Along with that, it also downregulates certain downstream signaling pathways. So this is NEJ009 trial, which is non-small cell lung, advanced stage cancer, positive EGFR mutation, and they were exposed to first generation TKI geftinib plus PEM-carbo versus geftinib. And as we have seen that the PFS benefit is huge, it is 21 months as compared to 11 months alone in geftinib arm. Even an OS benefit has been seen to the tune of 50 to 51 months as compared to 38 months in geftinib alone arm. So again, this is an updated analysis of NEJ009, again depicting the numerical OS benefit of 49 months versus 38 months with geftinib. And again, it has shown a consistent survival benefit. So as we know, our Indian scenario trial from TMH by Dr. Noorona and Dr. Kumar Prabhash. And this was a trial again on the same line, chemo plus first line TKI versus first line TKI. Now the difference in this trial is that it resonates more with our Indian population. Here, 20% of the patients who are in ECOG performance status 2 were included, which is 20%. 20% of the patients who had upfront brain metastasis were also included. And majority of the patients who had brain mets also were exposed to whole brain RT. So as we can see here, the progression-free survival in the combination arm was 16 months versus 8 months in a single arm. And the median OS data is still awaited. So definitely in our Indian scenario where cost is an issue, this trial has given us a ray of hope of providing a PFS benefit which resonate with that of osimertinib. And again, we have seen the OS benefit of combination goes up to 37 months versus 25 months. Now, what are the pros and what are the cons of the combination? Definitely an impressive progression-free survival, close to third generation TKI, increased overall survival as we have seen in Japanese trial, 51 months versus 38 months, and maybe more affordable in our Indian scenario. But again, regarding the toxicity profile, we have seen in our Indian trial also, there were 51% adverse event in the combination arm versus 25% in a single arm. Again, there is a wide variation in TMH and Japanese data. And what about the blood-brain barrier activity, of which we are not sure? And no chemo-free interval was seen. So rest of the trials now, we have seen TKI combination with chemotherapy. We have discussed about it. Definitely a very impressive trial and a very good data and very applicable in our Indian scenario. The next combination of first generation TKI is with the anti-VEGF therapy. So we have erlotinib plus ramucirumab, which is a relay trial. And we have erlotinib plus bevacizumab, in which we have a Japanese trial, and NEJ-026. And we have seen in both the trials, there were a benefit in progression-free survival. So this is the first trial, ramucirumab plus erlotinib in untreated EGFR mutated advanced non-small cell lung cancer, which is a relay trial. And ramucirumab plus erlotinib, the median progression-free survival is quite impressive, 19 months versus 12 months in placebo plus erlotinib. Even the median OS, though it was not significant, but numerically it was close to 51 months, which we have seen in the Japanese trial, NEJ-009 for first generation TKI with chemotherapy. Now, what are the pros and cons of TKI plus anti-angiogenic therapy? So for stage 4 lung cancer, when we have an oral option, convincing a patient for an anti-angiogenic therapy is quite a challenge. The additional cost plus the IV injectable plus the additional toxicity of anti-angiogenic therapy, and calling a patient after every 2 weeks is a challenge. Definitely impressive result, like increased progression-free survival, almost as high as FLAURA, but again with no OS advantage and with a usual toxicity profile of an anti-angiogenic. This particular combination we can use in high risk or certain subtypes, like the patient who have upfront brain metastasis or the patient who have L858R mutation, because L858R mutation has shown a consistent benefit, same as deletion 19 in this particular trial. Now, geftinib plus chemo versus placebo plus chemo. After progression on first line geftinib. So once the disease progress on geftinib, can we use geftinib in combination with chemotherapy? And the results were not so impressive. But on the basis of these results only, the next phase 2 trial was the OPAL study, This was a trial of osimertinib in combination with platinum plus pemetrexate in untreated EGFR mutated advanced non-small cell lung cancer. Again, this showed a consistent benefit with an increased overall response rate and progression-free survival. On the basis of this phase 2 OPAL study and the encouraging results in terms of overall survival, overall response rate and progression-free survival, as we can see in these graphs, the next trial which was done was FLAURA2 trial, which was the combination, which was a phase 3 trial of osimertinib in combination with platinum plus pemetrexate versus platinum plus pemetrexate. And it has shown a consistent benefit in progression-free survival to a tune of 25 months versus 19 months, which we see in osimertinib arm. Along with that, there was a very good benefit in CNS progression-free survival, which was 27 months. So in FLAURA2 trial, we are giving osimertinib plus platinum and pemetrexate. We are giving the best combination upfront. We are generating a very good PFS and OS benefit, a very good PFS benefit. Rather, OS is still exploratory and it has not been. Still the results are ongoing. But the only point is that do we need to expose our patient upfront to osimertinib plus chemotherapy upfront when we already have a very good third generation TKI with very less toxicity? In combination therapy, definitely the toxicities are also more. Moreover, we do not know that what is the mechanism of resistance which will emerge when we expose patient upfront to osimertinib plus platinum plus pemetrexate. So definitely these studies are encouraging, but we need to stratify the patients in which we can actually give such intensive therapy, either in terms of patients who have uncommon mutations or patients who have certain co-mutations or patient who have EGFR mutation plus TP53 mutation or patient who have upfront brain metastasis, and these need to be explored with more follow-up and with more studies. So again, this was one trial of concurrent versus sequential TKI plus chemotherapy. And here the patients were randomized into two groups. One is only geftinib, second is geftinib, followed by chemotherapy, followed by geftinib. It is just to, maintain the sensitivity to the TKI. And along with that, also to monitor intratumor heterogeneity and to make the sensitivity towards the TKI alive. So this therapy or this trial was based on the same. And definitely the median progression-free survival was improved when we did a sequential GEF followed by chemo, followed by GEF, that is 18 months versus 12 months. But again, this did not translate into an OS benefit, and moreover, more studies would be required to make this as a standard therapy. Again, newer and newer combination therapies are emerging. So one such trial was WJOG 9717L trial. Again, the same eligibility criteria, non-squamous non-small cell lung cancer, advanced stage, and EGFR mutated, exposed to osimertinib plus bev versus osimertinib. And progression-free survival was the primary endpoint. And again, it has seen that there is some benefit in progression-free survival, which is 0.86, but not very impressive. Moreover, we need to utilize this therapy in a very selected group of patients, which we are still unable to explore. Maybe the patient who upfront present with symptomatic brain mets, osimertinib plus bevacizumab could be one of a good therapy. But we have already seen, even with the osimertinib single agent, we have almost hazard ratio of 0.47 to 0.50 in CNS progression also. So we need more trials to actually select a subgroup of a population in which we can expose these combination therapies. so that we can justify the increased toxicity versus the benefit which we can provide in this particular subgroup. Now, this is the gist of all the first-line EGFR TKI mono or combination trial, and we all know FLORA trial, 38 months with osimertinib OS benefit. LUX-Lung 367, these are the trials of afatinib in comparison to chemotherapy or afatinib in comparison to geftinib, as seen in LUX-Lung 7, with an overall survival benefit of 28 months. Archer, decomatinib versus first-line TKI, 34 months. NEJ 005, 41 months. JO2 5567, again, there was 47 months. Then NEJ 009, 51 months. And we have our Indian combination trial where the progression-free survival was 16 months versus 8 months with first-line TKI. And the OS data is still exploratory. Now, recent trials, as we have already discussed, that the combination regimen, Japanese trial, 52 months, 51 months OS benefit. Erlo plus bevacizumab, 47 months. Then osimertinib alone, 38 months upfront. Decomatinib, 34 months. And afatinib in LUX-Lung 7, 28 months. So this just gives us an idea that when we can make different combinations of either first-line TKI with chemotherapy or first-line TKI with the anti-VEGF therapy, and we can extend our overall survival to the tune of 47 to 52 months. So, in conclusion, third generation TKI, single agent appears to be an appropriate choice. TKI with chemotherapy, definitely more practical and more cost effective. TKI with VEGF has actually failed to prove its superiority in terms of overall survival benefit, but combination also comes with added toxicity. Now, what about uncommon EGFR mutation and how common these uncommon mutations are? So is uncommon mutation a heterogeneous group? So exon 18 versus exon 21 compound mutation and exon 20 insertion. As we have seen the previous speaker.
2 minutes, please.
Okay. So as we have seen the previous speaker highlighting the role of NGS and newer compound mutations being emerging to the tune of 30 to 40% upfront. And more these uncommon mutation, the response to TKI is very low. And as we see the subgroup analysis, we have seen L858R has shown in all the trials a poor overall survival and PFS as compared to DEL19 mutation. So again, the same thing is reflecting that in L858R, the outcomes are poor. Probably one of the reason is because it has more number of co-mutation. So afatinib is one of the drug which is quite effective against these uncommon EGFR mutations. And the uncommon mutations are classified into 3 categories: T790M, exon 20 insertion, mutation or duplication in exon 18 to 21. This 18 to 21 mutation and duplication, afatinib has shown good activity. Whereas for exon 20 insertion, we have seen mobocertinib and amivantamab as actually, and lazertinib is showing a very good result. And in T790 mutation, we know in second line, osimertinib is the drug of choice. And we have seen certain, this is a real world study of afatinib followed by osimertinib, which is a geotag, and a median overall survival benefit was 41 months, and in DEL19 it was 45 months. So definitely a sequential therapy of targeting second generation TKI followed by a third generation TKI also helps in prolonging the overall survival, and it could be one of the strategy which is cost effective. But the only thing is how many patient post afatinib would eventually go and to a second line osimertinib, that we would be seeing in more and more clinical trials and real world scenario. Thank you, and I conclude my talk.
Thank you, Dr. Pooja. That was exhaustive presentation of EGFR mutated lung cancer. In our country, somehow in my side, we are having very few EGFR mutated lung cancer as compared to Punjab. Probably smoking related, we have more smokers here as compared to Punjab. And then, of course, giving this expensive treatment, very few I have been able to give. And I still believe that for our country, at least the trial by TMH has got a lot of value. And of course, you have to have a fit patient for those. And what lung cancer is seen as generally in elderly where fitness is always an issue. So thank you very much. If there are any question by anyone, please. If none, thank you, Dr. Pooja, and we proceed to the next presentation. This will be a panel discussion, management of resectable lung cancer. It will be given by my colleague from Paras Hospital, Dr. Chitresh Agarwal. Dr. Chitresh, you are there. You please introduce your panelist also.
So thank you, sir. And I would request the organizers to please, share these slides. And I would request all my panelists to please unmute themselves. Are my panelists there?
Yes.
So we can see Dr. Piyush attending ESMO probably.
Yes.
So rather than attending this panel discussion, I think we should hear it out what is happening at ESMO.
Oh, you can, yeah, we'll tell you definitely.
Once you come back, we should have best of ESMO by Dr. Piyush then. So I request all my other panelists to please be visible and say hello, quick hello, so that we can start.
Yeah. Am I audible?
Yes, you are.
Hi, Dr. Chitresh. Good evening, Dr. Ankit here.
So I know Dr. Piyush, he is a medical oncologist. The next panelist, please introduce yourself.
I'm Dr.
Hi,
Anish.
Dr. Chitresh.
Yeah, ma'am.
Hi,
So
I'm Dr. Deepika. I'm a radiation oncologist.
Nice. Next.
Yeah. Hi, I'm Dr. Anish. I'm a surgical oncologist.
Okay.
I'm Dr. Ankit. I'm a medical oncologist.
Okay, so we have two medical oncologists, one radiation oncologist and one surgical oncologist in our panel today. So to start, the topic is resectable or early stage lung cancer. So I would start with the surgical oncologist's perspective about what is early stage lung cancer and how frequently do you encounter these type of cases in your practice?
Early stage lung cancer, as it's been shown in the slides. Anything that is, probably a node negative disease or till T3, T4 or N0, even for that matter, we won't call it early stage, but still a resectable thing. So as per our practice, what we call an upfront early stage resectable lung cancer, T1, T2 disease with a node negative disease or probably an N1 disease. And it's been discussed in various previous presentations, we encounter it very less frequently, especially in whatever limited practice that I have seen. Dr. Debashish pointed out that, we have it to the tune of maybe 20 to 25% of lung cancers. But I'll say, and probably Dr. Nitish will agree, in our scenario, we hardly get up to 20% of early stage lung cancers.
Correct. So I would echo the same sentiment that we have very few patients who are upfront operable, lung cancers. Nowadays, there is a huge, heterogeneity in the definition of early stage lung cancer or a resectable lung cancer versus a non-resectable lung cancer that will, see in the subsequent slides. So moving on to the anybody who is having or who sees more percentage of early stage lung cancers in their practice. Anybody can comment.
I don't think, sir, we see the resectable lung cancer in our practice because it has been masked by the presence of tuberculosis in our country. So we tend to treat the patient for tuberculosis first, and then in case that is not responding, then the patient.
So point well taken. So moving on to the next slide. Next slide, please. So here is a 45-year-old male, non-smoker, hypertensive, no other known comorbidities. He underwent a routine health checkup and he was incidentally detected to have a small SOL in the right upper lobe. Next slide. So I think anybody of you can take this. So what investigations to be done next? How will you like to evaluate such a patient? I think I should start with Dr. Anishen again because, rather than a medical oncologist, probably these patients would be ending up with the surgical oncologist first.
Yeah. I think most of the times that clinically or practically we encounter patient has already been, a baseline CT scan is usually been done outside, a contrast CT is done. So if we find the findings of CT scan, we find them to be suspicious for malignancy. So I think there are two approaches to it. Guidelines say that you do a workup and then you need not do a pathological diagnosis. For such a case, you can go ahead straight away for some surgery. But most of the times we do get a preoperative tissue diagnosis, and as far as the metastatic workup and those things are concerned, we'd like to get a PET scan done. And if PET scan features are suggestive, further they corroborate with the CT scan findings of malignancy, then mediastinal staging, either by EBUS or EUS, or if possible by a mediastinoscopy.
Okay, so this is the approach by Dr. Ani. So, what is your preference? I would like to, at your center where you are practicing. So, for every patient that comes, for such a group of patients that come to you, so what would be your next step? Would you be interested to do a PET scan first, or would you be interested to see a histological diagnosis first and then do a staging workup, or how do you work up?
Most of the times we do get an upfront tissue diagnosis by whatever approach feasible. If it's a centrally placed lesion, we'd like to do a bronchoscopy and a biopsy. If it's a peripherally placed lesion, we do a transthoracic biopsy for that. And then again, like Nitish pointed out, in our scenario, we have a lot of other conditions to mask a malignancy. So getting a PET scan without a tissue diagnosis, we usually do not do that. So we get a tissue diagnosis, and if it's positive, then we go for the metastatic workup and further workup.
Well, point taken. Next slide, please. So this is your, the gamut of investigations that are mentioned in this, CT scan, oblique PET scan, MRI brain, routine blood test, OCG, 2D echo, PFT, biopsy, and a straight surgery or a frozen section. So I think what we have discussed till now is that straight surgery definitely is generally not done until unless we are able to prove that it is a malignancy. And though generally patients would come up with a CT scan, after a diagnosis of biopsy, we would definitely do a whole body PET CT scan to see the staging, and that would give us an idea about the mediastinum also, and then we would plan accordingly. So anybody who has something to add to this, or we should move further? Anybody who would do something different or something extra to this till now?
So I think one point that I would like to add, again, if we go by NCCN guidelines, they say to go for a mediastinal staging by any method. It's better to go and undergo one sitting, even if you're doing an EBUS or a mediastinoscopy, to do under the same sitting as you're planning the surgeries. But then again, practically, those things are not feasible at, I think, most of the centers in India right now. So we do like to, if it's a proven malignant case, before going for any definitive surgery, we do like to evaluate the mediastinum by any of the 2-3 methods that we have available.
So what is your preferred choice to stage
So
a
usually
mediastinum?
we do get an we do get an EBUS done because mediastinoscopy we do not have available, so we rely more on EBUS. And so far the results with a preoperative evaluation of mediastinum with EBUS, we've been very happy with the results. So we usually do an EBUS.
So suppose it's a peripheral 1 centimeter tumor and it is clinically T1, will you still do a EBUS, or
Yes, sir.
you take
Okay.
the face
So,
value of PET scan and accept what it is?
this is again more of a theoretical thing for discussion, because by and large I don't think I'm yet to see in my practice a lung 1 centimeter nodule proven malignancy that probably we are going to go for a definitive treatment. But yeah, your point is absolutely right. For a lesion peripherally placed that is less than 1 centimeter, you can rely on PET definitely for mediastinal staging. But I think anything that is more than one, maybe let's say 2-3 centimeter lesion that you're encountering, so I think it's always better to go for preoperative mediastinal staging rather than going for an upfront surgery.
Dr. Ankit, you would give your opinion here. So if a peripheral, if you, your approach would vary, say 1 centimeter versus 2 centimeter peripheral lesion, would you subject all these patients for, a mediastinum staging, or a PET scan would suffice for you?
So I think the chances of having a mediastinal node positive is very bleak. I think that would be just a single digit percentage if we speak in terms of strict percentages. But still, if it's a high volume center and we start doing not a surgical procedure, maybe just a EBUS, I think we still pick up few patients, maybe just 2 or 4 out of 100 who are mediastinum positive, node positive. So I think if that is the approach, then I think EBUS would add to that. But definitely an invasive mediastinal staging, I would not follow.
Yeah, I totally agree with this point, because an invasive mediastinoscopy is maybe a step too far. But if you have an EBUS available, and then I think for a lesion that is maybe more than 2 centimeters, it's if you have that option, I think it's better to go with that.
And just along with that, maybe EBUS might be available, but you need to see the expertise also of the person sitting behind that EBUS.
Absolutely.
So I was coming to that point, that though EBUS nowadays on paper is available in most of the, the corporate hospitals, but the so-called expertise is yet not there at many centers. So I think it is a long learning curve for everybody. And your point is well taken, Dr. Ankit, that if EBUS can add something to this, you should definitely go for it. But for centrally, for a peripheral tumor for 1 to 2 centimeters, if EBUS is not available, and histological diagnosis is of malignancy available with us, then probably PET scan at majority of the centers in India till now does the job for majority of the patients. So moving on to the next slide. So this was the contrast enhanced CT thorax, where you can see the peripheral lesion lying beautifully in the lobe. And moving on to the next slide. No, the previous one. So the finding was a 1.5 into 1 centimeter SOL in the right upper lobe, a peripheral lesion, mild spiculated margin, no nodes in contrast. And so at this point, we have already taken that instead of going for a surgery upfront, we would do a biopsy to confirm that it is malignancy. Next slide, please. So the central lung tumors approach of bronchoscopic is somewhat different. But for peripheral SPNs, it is a diagnostic challenge, because the incidence of malignancy across studies, it ranges from 10 to 68%, depending on the definition of a solitary pulmonary nodule and the selection criteria for the patients. So the clinical risk factors for malignancy include age, smoking, history, hemoptysis, and a prior history of malignancy. And this all we agree to. To the next slide, please. Next slide, please. So a TFNA biopsy for pulmonary lesions are useful in lesions of at least 2 centimeters. And these studies demonstrate a diagnostic yield of near to 60% for lesions which are smaller than 2 centimeters for peripheral lesions at high volume centers. Next slide. So next, what will you do? So a CT scan with the contrast has been done. You know it's a solitary pulmonary nodule. You know its architecture. You know its location. So what next? So will you be interested in a PET scan or some other investigation at this point?
Is the next step.
So yes, we will definitely do a PET CT scan in this. So next slide, please. Next slide, please. Next slide, please. So PET, FDG, PET CT is superior to CT. This we all know in differentiating between tumor and post-obstructive atelectasis. Next slide. So PET studied extensively for evaluation of indeterminate lung lesions. Its accuracy in differentiating benign from malignant lesions is as small as 1 centimeter. And if we see the overall sensitivity is quite high, it is around 96%, and a specificity of around 18 to 80%, and an accuracy of around 90%. So false positive FDGs, upticks can be seen in inflammatory conditions, especially the inflammatory conditions of tuberculosis in our country. But still, I feel PET is a very important investigations to see for the mediastinum in such group of patients. So moving on,
Dr. Chitresh,
yes,
not just because of higher sensitivity and specificity. Me being a radiation oncologist, I can vouch for PET CT because, when we are, especially for early stage lung cancer, when we are planning SBRT specifically, then having a PET CT is very important. In fact, we do a PET CT fused RT-based planning, so that sometimes there is a collapsed lung just adjacent to the tumor. So on normal contrast enhanced CT, it is very difficult to identify, and we can actually take that entire thing in our PTV. So like post-obstructive atelectasis, it is very much important to differentiate that from the actual tumor. So for that also PET is...
Definitely. So ma'am, there is no doubt about that point. The only thing is that this PET, the point that I was trying to make was that PET, according to its ability to pick up the disease cancer. Obviously, your point is very valid taken, that while treatment decisions are being made, normally nowadays, no treatment decision should be done or is being done without a PET scan or a good PET scan.
Absolutely.
So moving on to the next slide. So PET, as we have discussed, is important in early stage lung cancer because preoperative staging with PET and cranial imaging identifies more patients with mediastinal and extrathoracic disease than the conventional staging. And therefore, it spares more patients from this stage inappropriate surgery. But this strategy also incorrectly upstages some patients, where it was early disease, but PET thought that this node was positive, or we interpreted that node to be positive, and we tried to upstage the disease from either N0 to N1 or N1 to N2. Next slide, please. So PET CT has a low specificity for mediastinal staging of non-small cell lung cancer, because it is especially valid for a country like ours where tuberculosis is an endemic problem. And a study was done to show the diagnostic test study, which was designed to evaluate PET CT performance on the diagnosis of metastatic mediastinal lymph nodes compared to the gold standard, which was invasive staging with biopsy in patients with non-small cell lung cancer. And you see the rate here, it is false positive of 54.8%. So PET CT scan must not be solely used to, as a tool to mediastinal staging, and especially in a country like ours where there is a high burden of tuberculosis, and this we were previously discussing also, that PET has its own role, but where available, we should always go ahead with, EBUS and a TBN or an FNA to prove or disprove a specific, node or disease. So moving on to the next slide. So this was the whole body PET scan, and as far as I see, the uptake is only seen on that peripheral lesion. Moving on to the next slide. So now what? We have done a PET scan. We know the exact staging. We have a diagnosis of lung cancer. So now what will you like to do? Dr. Ankit or Dr. Anish, anybody can answer.
So now the next question comes. There are two questions: whether we need to address this, we need to see the mediastinum, do the mediastinum staging or not, and second is whether to do a tissue diagnosis before surgery or direct surgery. So these are the two important questions.
So first we will answer. Yeah, first you answer these two questions, then we'll hear Dr. Anish answer these two questions.
So I think in this particular patient, being a peripheral lesion, very small lesion, 1.5 centimeter, if we have a expertise with EBUS, would like to just do away with that, not for invasive mediastinal staging. And for tissue diagnosis, definitely we would like to discuss with our interventional radiologist if it is easy and safe to do, would do a transthoracic FNA. Otherwise, I'm comfortable with upfront surgery also.
Okay. Dr. Anish, will you be comfortable doing an upfront surgery, or do you always require a histological diagnosis in such patients?
So, sir, I actually echo with Dr. Ankit's viewpoint. Like, I would definitely want, I would discuss it with my interventional radiologist if it's possible to get a transthoracic biopsy or FNA. I would definitely would like to have that so that we have a pre-op diagnosis. But if like it's a very small lesion, or it's not possible for my expert interventional radiologist to get a tissue diagnosis, so then again we'll go ahead with the surgery. But then I would like to involve my pathologist for a frozen section before going for a definitive lobectomy, or whatever definitive resection, so that we have at least some intra-op diagnosis for that. And as far as the mediastinal staging is concerned, like I initially also said, that we are more comfortable with just doing an EBUS, and for this small lesion, peripheral placed lesion less than 2 centimeter, I'll be more than happy with an EBUS and not go for an invasive staging.
So I agree to what you are mentioning, that invasive mediastinal staging is, if available, we should definitely, by EBUS it is okay. Mediastinoscopy is too aggressive for this patient, and upfront surgery, could be done, but before you actually go in for a lobectomy or a segmentectomy or whatever surgery you are undergoing, these patients actually need some confirmation that it is malignancy. So, Dr. Anish, what surgery would you offer for such a group of patients in your practice?
So, sir, by and large, we still prefer doing a lobectomy. That is the minimum resection that we do. Since the patient's general condition, if it's good, with sufficient lung reserve and a healthy amount of lung tissue, and if the patient can tolerate, then we still go for a lobectomy. Although now we have sufficient data to point out that for such small lesion, if segmentectomy oncologically, it has similar results as compared to a lobectomy. But if you ask me, in my practice, we usually do lobectomy as a minimum resection.
So for a layman like me, I'm a medical oncologist, just to have a brief, understanding of how do you choose your patients for, like, whom to offer segmentectomy or whom to offer a lobectomy, or there is no such criteria?
Sir, by and large, like I said, if at all, being a surgeon, I'll tell you, lobectomy is technically more easy to do as compared to segmentectomy. And the conventional teaching has been like that lobectomy is the minimum resection. But for if we have a patient with a very compromised lung, or we feel that doing a lobectomy is going to pre-op PFTs, they indicate that predictive outcome of lobectomy also is going to hamper with the lung function or the lung reserve. In those cases, and it's a small lesion and we can get a comfortable margin of 2 centimeter all around. In those cases, you might go for segmentectomy, but then practically speaking, we usually do not go for a segmentectomy for two reasons. One is that, like I said, we do not encounter such small lesions. And secondly, like I said, most of the times the lesion, it's somehow reaching to the lobar bronchus, or it's crossing the fissure, or let's say the fissure is not well defined. So all those anatomical considerations we have to take into account. So by and large, we do a lobectomy.
So this 2 centimeter margin is mandatory for lung surgery, or this is an arbitrary,
So, sir, this is a 2 centimeter gross margin that we say, but then, I think this is like more of a institution-based practice or teaching-based practice. We do not have a very definitive criteria, like for certain other malignancies, but this is the practice that we follow. At least, we are more comfortable when we have a 2 centimeter gross margin.
So, Dr. Ankit, at your institute, you are offering lobectomies or segmentectomies to such group of patients?
I think mostly lobectomy. Very rare we have seen segmentectomy.
Segmentectomy. Our radiation oncology, ma'am, any input from your side?
The standard of care is lobectomy at my center. That's it.
Okay, so we also, a couple of patients that we have done in last couple of months, we also have seen only lobectomies being done. And I think the surgical oncologist, howsoever small a lesion is, till now, I think I've discussed it with my surgical oncology colleagues also. They are more comfortable offering a lobectomy rather than a segmentectomy in these patients. This is what is my practice. So moving on to the next slide.
2 minutes, please.
So then we have to rush. I will just go through these slides because we are getting late. So as per the American College of Chest Physicians guidelines on nodal staging, further invasive staging can be waived for a patient who has a small size peripheral primary tumor, less than 3 centimeters, and a radiologically normal mediastinum. Next slide, please. So this is what I will just make the gist that for a central tumor or a solid tumor which is more than T2 or so, it makes more sense to evaluate the mediastinum. And for such patients, we might even go for a more invasive testing. Next slide, please. So does peripheral T1A or B lesions have lymph nodes? As Dr. Ankit mentioned, that it would be a probability of a single digit, anywhere between 4 to 10%. And as the nodal incidence of N2 or more increases, then the possibility of it increases far more. Next slide, please. Next slide, please. So invasive mediastinal staging was not done for this patient in view of a peripheral tumor and a size which was less than 2 centimeters. Next slide. So surgical choice we have discussed, and it is lobectomy. And though I will show you in subsequent slides that there is enough data to, as Dr. Anish mentioned, segmentectomy, but still lobectomies are being done very commonly. Next slide. So traditional studies recommended lobectomy, and the recent evidence is changing. Next. Next. So this was the JCOG trial, which showed that it was the first and only randomized trial to show the superiority of segmentectomy over lobectomy in overall survival for early stage lung cancers. Next slide. So any role of SBRT? Just a very good question. Any role of SBRT, ma'am?
Yes, definitely.
Or if so, what are the so Dr.
See,
Anish?
generally, if we say about the data available, it is for surgically or medically inoperable patient. That is, when patient is not fit for surgery because of comorbids or because of age, or if a lobectomy is not possible and patient is offered anything less than a lobectomy, then SBRT has got a really good data. So there are head-to-head comparison with SBRT with surgery, and we have seen that local control and loco-regional control overall survival is quite comparable to surgery in early stage.
Ma'am, but what about your comment on the lymph node dissection status? Because any of the
Yeah,
patient
see, that is the gray area. That's what I'm telling you. It is only for very early stage.
So, sir, I was also about to come to that point. Like ma'am pointed out, for that particular lesion, again, SBRT and surgery head to head, we have sufficient data to say that local control and, otherwise they are comparable. But still, being a surgeon, of course, that is my bias will stay towards that. But apart from that, like you pointed out, issue of lymph nodes, one that is very important, since we talk so much about lymph node staging, sampling, or systemic dissection. So that issue remains unaddressed with the SBRT. And second thing is, we might some occult lesion within the same lobe. I think it's mentioned in your slide also. We again, with surgery we get a better pathological diagnosis, or pathological staging of that particular lesion. So for those two reasons, but otherwise, yes, totally agreed to this thing. If the patient is medically inoperable or due to some comorbidity, some issue, we do not feel that the patient has sufficient lung reserve to maybe tolerate even a lobectomy. So for those patients, SBRT, excellent choice.
So now last question, 1 minute, and then we'll stop. We are short of time. And surgical oncologists have to just answer one question or his thoughts on, this lymph node sampling versus lymph node dissection. It's a huge debate now. So how do you do, and what is the difference?
By and large, we go for a systemic lymph node sampling. We try to sample a minimum of 2 nodes from each station, and one of the that is again specific to the site of the disease. And invariably, one of the station, it has to be a subcarinal node, and you need minimum of 3 or N1 stations and 3 or N2 stations, and 2 nodes from each. Minimum of at least 10 nodes should be harvested. So these are the principles that we go by. By and large, we do not do a complete systemic mediastinal dissection. We rather go with systemic mediastinal sampling.
So I think in want of time, I would stop here, and I would hand over back to the organizers. Thank you.
Thank you, Dr. Chitresh, and all the panelists. That was a lovely discussion, especially early stage disease. And we're going to have a lesser surgeries as the new adjuvant immunotherapy comes. So for that, I have with me Dr. Vijay Simba. He's from Bangalore. He'll be talking on optimizing the use of new adjuvant immunotherapy in non-small cell lung cancer.
Thank you, sir. Am I audible?
Yeah, you're audible.
I would just like to share my screen.
Okay.
Now I've put it on full screen mode.
It is visible. Please.
So we are running short of time. I will try to keep this as short as possible. So the topic that Dr. Nitish asked me to talk about was optimizing use of neoadjuvant immunotherapy in non-small cell lung cancer. I congratulate Nitish and his team for putting together this very nice topics which are less touched upon, especially in lung cancer and in the neoadjuvant setting. Definitely not something that we do every day. So we know that surgery alone does not cure majority of the patients with non-small cell lung cancer. And LACE meta-analysis has shown us that adding adjuvant chemotherapy to resected non-small cell lung cancer confers a modest survival benefit of around 5.3% at 5 years. And similarly, neoadjuvant chemotherapy also prior to surgery improves overall survival with a hazard ratio of 0.87, which we can at best call modest. And also it confers around a 5% modest survival benefit. Now, we all know that immunotherapy is highly effective in extending overall survival in the metastatic setting. So in the early setting, the goal compared to metastatic setting is actually to increase the cure rates. So in this use of neoadjuvant immune checkpoint inhibitors in the pre-operative, post-operative, or even as a peri-operative strategy. In this talk, I'll try to show how this neoadjuvant strategy can be exploited therapeutically so that we can maximize the clinical outcomes in resected non-small cell lung cancer. We just had a very nice panel discussion, but I have to say that where I practice, even though we call ourselves a tertiary cancer hospital in Shankara, the number of patients whom we ultimately end up operating is actually very less. And if we see the Western data, around 20 to 30% of all lung cancers are operable. And if we see the Indian data, even though the incidence is very similar, this is the data that is from AIIMS New Delhi. It is a clinical profile of lung cancer in North India, a 10-year analysis of 1,800 odd patients, and the number of patients who belong to the early stages is around 25 to 30%. But still, in that particular paper, they observed that less than 3% of the patients underwent surgery. So if we see the numbers, that is actually quite a low number, around 55 to 60%. 55 to 60 is that absolute low number. And so we need to improve upon that. So now immunotherapy, as we know, we can use in neoadjuvant setting or adjuvant setting. If we use immunotherapy in adjuvant setting, we will be dealing with a low burden of micrometastatic disease, which is an advantage. And the number of clones that have evolved from the tumor growing is less. So there is lower subclonal divergence. And it has been noted that there is stress after surgery, which is due to the release of significant amount of cytokines. So therefore, there is an immunosuppressive microenvironment after surgery. So the use of immune checkpoint inhibitors may potentially reverse or at least neutralize that immunosuppressive effect. So this is a cartoon to show that after surgery, due to the post-surgical stress, there is activation and expansion of regulatory T cells, which may lead to immunosuppression, which may be overcome with immunotherapy. In the neoadjuvant setting, use of immune checkpoint inhibitors confers a totally different type of advantage, in that the efficacy of immunotherapy is maximized because of the high neoantigen burden, and also there is limited heterogeneity of the tumor, and a broad T cell response can be exploited due to the large repertoire of tumor neoantigens that are present when the tumor is intact. And it enables tumor conditioning right from the beginning, and it enables expansion of tumor-specific memory cells early in the course of disease, which continues on during the preoperative period, the perioperative period, and also the postoperative period. That is the advantage of neoadjuvant, giving immune checkpoint inhibitors in the neoadjuvant setting, that we have a broader repertoire of anti-tumor CD8 killer T cells, and that can carry on to the postoperative period. So immune checkpoint inhibitors, as when we see the data, initially it was tried in the single-arm Nadim trial, where only 46 patients, many of them with N2 disease, where it was a single-arm study where 3 cycles of paclitaxel carboplatin neoadjuvant nivolumab was added along with paclitaxel carboplatin, and they saw that they had a major pathological response. Major pathological response is presence of less than 10% of viable tumor cells on the histopathological specimen, which was 83%, and 63% had pathological complete response. And 89% of the patients underwent an R0 resection, conferring so far never heard of progression-free and overall survival at 3 years of 79% and 82%. And exploratory analysis looking at PD-L1 and tumor mutation burden showed that neither of the two correlated with progression-free survival and overall survival. Nadim by itself was a single-arm study. Then we needed to compare it with surgery versus chemoimmunotherapy followed by surgery. And Nadim 2 just proved it, that the PathCR response was higher with 36% in those who received chemoimmunotherapy versus chemotherapy alone. And the maximum pathological response 52.6% versus 13.8%. That is almost more than 50% of the patients achieved major responses on the histopathology by the combination of immune checkpoint inhibitors and chemotherapy. And the extent of R0 resection after addition of neoadjuvant immunotherapy only improved the R0 resection rate. And Nadim-2 was the first trial to show that combination of neoadjuvant chemotherapy with immuno-oncology, that is with nivolumab, extended the progression-free survival as well as the overall survival. Both were significantly improved. So now came the phase 3 trials, the most important phase 3 trials, which tested immune checkpoint inhibitors only in the neoadjuvant setting, but did not allow any maintenance with immune checkpoint inhibitors, was the Checkmate 816 trial. So this was an open label phase 3 trial. It stratified patients by stage, PDL1 and the histopathology. Patients were randomized to nivolumab, combination of nivolumab with chemotherapy for 3 cycles versus chemotherapy alone in the neoadjuvant setting, and then underwent surgery within 6 weeks of completion of neoadjuvant chemotherapy. And optional adjuvant treatment was optional, chemotherapy or radiation. The primary endpoints were progression-free survival and event pathological complete response rates and event-free survival. And secondary endpoints were overall survival and major pathological response. It was shown that the pathological response in those patients who received nivolumab plus chemotherapy was 24% versus only 2.2% in chemotherapy alone, which is a major landmark. And also this translated into significant improvement of event-free survival, which was not reached in the nivolumab plus chemotherapy arm versus 21 months in the chemotherapy arm. Similarly, overall survival data, both the arms did not reach the median overall survival at the last time of reporting. But however, the nivolumab arm had significant superiority in terms of overall survival also. And there was improvement in PATH-CR across the subgroups, and it was seen that the magnitude of the event-free survival was greater in those who had stage 3A disease, had higher PDL1 expression and non-squamous histology. And what this trial showed was also that the pathological response and survival correlated with each other, in that patients who had a superior pathological complete response had a higher overall survival. And similarly, this was also seen with major pathological response, in that those patients who had a major pathological response versus those who did not have a major pathological response had a significant difference in the survival, and this was statistically significant. So additional analysis also showed that there was an effect of using nivolumab in the neoadjuvant setting. It showed a lower rate of distant recurrence as well as a lower rate of central nervous system recurrences. This trial was just a preoperative strategy. There were similar trials which use perioperative strategy, which include the AGN study, the NeoTORCH study, and the Keynote 671 trials. So all these trials use immune checkpoint inhibitors in combination with chemotherapy prior to surgery, followed by maintenance with either the immune checkpoint inhibitor or placebo, which is given up to nearly a year. Keynote 671 was one of the landmark phase 3 trials. It was a double-blind study where patients with resectable lung cancer were randomized to receive pembrolizumab with chemotherapy or chemotherapy alone for 4 cycles, followed by surgery. Similar results like the Checkmate trial were obtained in the Keynote 617 trial. A higher incidence of major pathological response, 30% in the pembrolizumab arm versus 11% in the chemotherapy only arm, and also the pathological response, pathological complete response was 18% versus 4% in the placebo only arm, and this translated into a superior event-free survival, which was not reached. The median was not reached in the pembrolizumab arm versus 17 months in the placebo arm. And similarly, there was a difference in the overall survival, but was not statistically significant. The event-free survival was, the benefit was seen across all subgroups according to the stage and the other demographic factors. And similar to the Checkmate 816 study, the Keynote 671 also showed that if you attain either a major pathological response or a pathological complete response, that is associated with superior survival. So by using chemoimmunotherapy in the neoadjuvant setting, we have a opportunity to at least identify the patients who will survive long versus those who won't survive long after our standard study. And because the addition of immune checkpoint inhibitors do not have any overlapping toxicity with chemotherapy, there were no significant increase in the toxicity that was attributed to addition of immune checkpoint inhibitors. For example, most of the toxicity was nausea and decreased neutrophil count, anemia, and decreased WBC count. Most of the things which are very mild, easily controllable, or just seen on the paper by the physician as a report. So not significantly increased in the adverse effect seen with addition of immune checkpoint inhibitors. So neoadjuvant pembrolizumab with chemotherapy followed by a perioperative strategy also improved the event-free survival, resulted in increase in the pathological complete response and major pathological response. This correlated with survival, and there were no significant adverse increase in the adverse events. The safety profiles were acceptable, and this also became a standard of care. Similarly, two other studies, which I'm not going to go into much detail. One is the toripalimab, which I've never used. Similarly, again, chemotherapy with toripalimab used as a perioperative strategy improved the event-free survival. The AGN study is another perioperative design where chemo plus immunotherapy, which this time is durvalumab, 1500 milligram given for 4 cycles along with chemotherapy, and then continued every 4 weekly for 12 cycles, that is a maintenance of 1 year after surgery, has resulted in improvement in event-free survival. The AGN study was the most recent study where almost half of the patients had N2 disease and 1/3 of the patients had PDL expression more than 50%, and the event-free survival was observed regardless of the PDL1 expression or the disease stage or the use of a platinum agent. So this is the event-free survival curve of the AGN study, where the durvalumab, the event-free survival median is not reached versus 25.9 months in the placebo arm. So this is just a cartoon showing the various neoadjuvant trials that have been done in non-small cell lung cancer. We can see that the red block that is there at the beginning of each study is the patients who underwent surgery. And we can see that with the use of neoadjuvant strategy, the number of patients who have undergone surgery has not at all been significantly reduced. It is more than 80, 85% or 90%. And the blue bar that is a second next to surgery represents patients who overall had a response. And again, this is upward of 60, 65, 70% in those where it was analyzed. And if you see the purple color bar, it represents the patients who had major pathological response, which again is very high, 83% in the Nadim study, and in the randomized studies, it has been seen up to 37% as major pathological response. And the PathCR also has been following the same trend in almost all the studies. So one study which I would like to point out is the addition of neoadjuvant radiotherapy with the immunotherapy, which is when I was looking at the data, this came out as a surprise, where patients were operable underwent SBRT of 8 gray for 3 fractions along with durvalumab, 2 cycles, was compared with durvalumab alone. And we could see that addition of radiation to durvalumab produced the major pathological response of 53% versus 6.7% with durvalumab alone. this leaves us to wonder how much of the major pathological response versus the pathological complete response is actually attributable to the immune checkpoint inhibitors at all. Maybe it is not the immune checkpoint inhibitors alone, but the actual combination of the immune checkpoint inhibitors with the chemotherapy, which perhaps is acting synergistically. And as we can see in this study, the major pathological response was 53% in those who underwent radiation versus 6.7% with durvalumab alone, and similarly PathCR in 50% versus none in the durvalumab alone. And again, the success of surgery, 87% of patients went on to undergo surgery. So use of SBRT in the neoadjuvant setting, combining it with the immune checkpoint inhibitors, who for any reason we're not being able to give them chemotherapy. This is a useful strategy. So to conclude, in patients with resectable non-small cell lung cancer, the addition of nivolumab to platinum doublet chemotherapy significantly increases the pathological response rates and prolongs the event-free survival and overall survival. This is the only data which deals with purely use of nivolumab purely in the neoadjuvant setting. Then there is the use of perioperative chemoimmunotherapy with immune checkpoint inhibitors such as durvalumab, toripalimab, and pembrolizumab. They increase pathological response rates and also prolong event-free survival, similar to the way nivolumab has done in the neoadjuvant preoperative setting. And also there is data for PD-L1 positive resected non-small cell lung cancer, where adjuvant treatment with atezolizumab and pembrolizumab after a platinum-based chemotherapy also significantly prolonged the disease-free survival. However, I was not able to touch upon this topic because it was not, it was beyond the bounds of my topic. So thank you. With this, I would like to take questions. And once again, thank you for this opportunity to so that I could present this data.
Thank you, Dr. Vijay. That was a wonderful presentation. Though the FDA has approved nivolumab in a neoadjuvant setting and pembro plus atezolizumab, depending on the trial in the adjuvant setting. So
Yes.
we have a good EFS advantage in this, though the overall survival has not come till now, because obviously even in Anita trial, it took 14 years to bring out the overall survival difference. So probably in a new this setting, post-surgery, it will take some time for the new overall survival also.
Yes, sir.
So thank you. If there are any question, if not, I hand over the mic to Dr. Nitish Garg, and thank him for giving me this opportunity. Thank you, Dr. Nitish.
Thank you, sir, for being a patient listener and moderating this session. And thank you, Dr. Vijay, sir, for the wonderful presentation. So with this, we come to end of this 2-day academic fest, discussing some of the rarer things which we don't see in a common practice. So I would like to thank my entire team to organize this event and make it a great success. And also a last thank to my sponsors. Thank you. Thank you, everyone, and have a good night.
Thank you, sir. Good night.
Thank you, Dr. Nitish. Thank you, everyone. And thanks for my colleagues, Nishan and Vishal, from all of us from the organizing team. Stay safe, stay blessed. Good night to everyone.
Thank you, Tarun. Thank you.